John Seelig, if you would go, and then we'll make those other changes as well. Thank you, committee. I appreciate your indulgence.
What exactly is a halo cost?
It means it's not just the behavioral health costs, but all the medical, all the costs for that patient.
Okay, so we talk about, so when they're talking about behavioral health and halo costs, they're talking about behavioral health. Then
In
they're
the
talking
medical
about
hospital,
everything else.
all the costs.
John, if you and your folks would introduce yourselves, and then you're recognized.
Thank you, Mr. Chairman. I'm John Seelig, Director of DHS.
Thank you. I'm Jim Brader, Director of Division of Developmental Disability Services with DHS.
I'm Craig Cloud. I'm Craig Cloud, Director of Aging and Adult Services, Department of Human Services.
And I know there's a button here to make this full screen, but I'm not sure where it is. What's that? Great. Thank you. Thank you, Mr. Chairman. I'll try to keep this brief. Just want to give you a quick overview of CFCO and kind of the work that we've done on it. As you all know, we've got a growing elderly and disabled population in Arkansas. It's true elsewhere around the country. People are living longer, and people with disabilities are living longer and surviving. So it's and as the Stevens Group has pointed out many times, serving those populations can be very expensive, and we need to serve them well, and we need to make good use of our resources. We've been working for quite a while in the department, and with the help of a number of you and Governor's office, going back a number of administrations, to try to make sure we have an array of options for people, anything from institutional care for those people who need it to options to help people stay at home and in the community. Most people certainly want to live at home in the community, and if that's what's appropriate for them, that's what we want to do. It's generally less expensive, but we also have a need for the services where people really can't stay at home and in the community. We've made a lot of progress, but it has been slow. We've got a long ways to go on creating home and community-based services, and while the federal government has encouraged us in all states to rebalance, to move more toward home and community-based services, they haven't actually provided a lot of support until recently. And I think it was 2012, maybe 2011, when the Affordable Care Act came around and some rules got finalized. One of the things that they created was the Community First Choice option, which said to states, if you will serve the people who are eligible for institutional care but want to live in the community, if you will serve all of those people who are eligible in the community, we'll give you a big break on the amount of state funding you have to put up, a 6% break in the amount of state funding, which for us would take us from 30% to 24%. That's actually about a 20% difference in what we have to pay for those services. So we were obviously interested in at least looking at it and discussed that with the Public Health Committee at the time. We were encouraged by the committee to look at it. We created an oversight or steering committee, I can't remember what it was called, of close to about 20 people from various interest groups to help us think through it. And based on the work of that group and our financial analysis, we determined that we thought Community First Choice would make sense in Arkansas if, and I really want to stress if it had the right controls. We did not want to and would not want to implement Community First Choice in Arkansas if it didn't have the right controls. And what I have here is the material that we presented to the Public Health Committee about a year ago, at which time the decision was, let's hold on this, let's wait for the new administration, get more information about Community First Choice. But I think most of the information in this presentation, which I'll go through pretty quickly, is still relevant. The numbers obviously aren't exact, and I would say up front, based on what you heard from the Stevens Group and our study since then, there obviously are different variations that different states have looked at. We're certainly interested in looking at those variations, and again, would not want to do this without the right controls, but it is something that we think could make a lot of sense for us. We have 3 waiver programs that serve different populations, 3 in particular that would be affected by the Community First Choice option. The Elder Choices waiver, which many of you are familiar with, that serves seniors. The Developmental Disabilities waiver program, DD is the first one listed here on this slide. The Elder Choices waiver, and then a waiver for adults with physical disabilities. You can see just examples of the types of services that those people in each of those waivers are eligible for. You can see the number of people on those waivers now, and some examples on the right of the types of people served by those waivers. The idea of the waiver is to give individuals and their families the supports they need to help someone stay at home or in the community, and by the community it might be in an apartment or a small group setting, rather than going into institutional care. And I want to stress, there's kind of a question about whether this is an entitlement. This population who would be eligible for the community first choice option, all of those people are currently eligible for institutional care. Today, they could go in a nursing home or into a human development center if there's a bed that's appropriate for them. So they are already entitled. What community first choice would do is say that entitlement extends to giving you a choice for home and community-based services, not just for institutional care. So it doesn't create any new eligibility or any easier eligibility. It simply says you are also entitled to home and community-based services. And I want to hit real quickly on the top group there, the DDS group, because that's the one that's had the most focus. As you can see, there is a large waiting list. In fact, we have gone back to the waiting list from a year ago, confirmed with each of those individuals who is and who is not actually eligible. For example, has somebody moved out of state? Have they died? Et cetera. Having confirmed that, and with the growth in the list, we're now up to 2,900 people who are confirmed eligible, who are waiting on the waiting list. And the waiting list, it's about an 8-year wait now to get these services if you were to get on the waiting list today. So it's an extremely long wait. Obviously, that's of great concern. You'll hear about that from some of the families. You heard from the Stevens Group that some of these people who are on the waiting list are getting services today. I think it's important to point out a couple things. One is, I think, Mr. Chairman, you asked about whether the two examples were outliers. And I know from being up here, it's difficult to look quickly at something like that. In fact, I was able to do some calculations later, and in fact, the two examples are outliers in that they're $30,000 to $40,000 in services. The average is about $12,000. And when you look at those slides from the Stevens Group on the services they're getting, much of what they're getting is just in that $12,000 average. It's just standard medical services, prescription drugs, it's transportation, it's doctor's visits. It is not services that helps them stay at home in the community. And in fact, the second largest expenditure in that group, from about $30 million, is for people who are currently in institutions, in human development centers or small ICFMRs, who are on the waiting list because they want to get out, but we haven't been able to help them get out and move back to the community. So the percentage of those expenditures that are actually helping people stay at home, from my rough estimate, is only about a third of those expenditures are for the types of services that people need to stay at home. So while they are getting some services, and obviously those are beneficial, particularly day treatment programs, they're not getting much that helps them stay at home. And in the example of Stacy here, it's the kind of case, and I think you may have heard about this when we talked about last year, it's the kind of case where she's at home now, but because she's at home, someone's got to stay at home with her. She can't go to church, maybe because of behavior issues. It may be that the parents, one of them has to stay up all night with them. It may be that she can't get out and do anything, and probably one or more of the parents can't work because she's got to have supports at home in order to stay at home, or she's going to need to go to a nursing facility or a human development center. So it's that type of support when you hear from these families that they're looking for. Is many of them really are just holding on, trying to wait long enough to get on this waiver program so they can kind of resume a normal life, and so that their child or family member can get the kind of supports they need. Here's just what kind of our analysis of Community First Choice real quickly. As I mentioned, you get a 6% improvement in the federal match rate. It doesn't create any new eligibility. You still have to be eligible for Medicaid. You still have to meet the nursing home level of care, just like you do today. And any other rules there that, like about your assets, are still in place. And there are a number of cost controls that we think are really important. We can change Medicaid eligibility rules. We could change, if we needed to, the definition for institutional level of care. The third one, I would say, is the most important, that independent standardized assessment, which was just talked about, which the Stevens Group has repeatedly talked about. We do not think you should do Community First Choice unless we have an independent assessment of those clients, tie that assessment to their level of need, and then pay based on that level of need. We do not do that now, and if we simply kind of pay for everybody to have a Cadillac service, we cannot afford to do that. And we have clients today in some of these systems who look like they're very similar clients, but for whatever reason, they're getting very different levels of resources. We need to tie that level of resources to what their needs is. We need to pay for what people actually need, but we don't need to be paying for more than that. And the only way we think we get at that, and I think there's national consensus on this, is you've got to have an independent assessment up front for the people who are particularly costly to make sure you're spending your resources wisely.
John, I've heard this now in several of these discussions where what it comes down to is, you know, somebody watching a gatekeeper to have some type of objective assessment. Because, you know, as a parent of a child with disabilities, if you ask me what my daughter needs, I'll give you the answer. It's everything you got and more.
Sure.
So I understand how as a parent we operate, and I know that as a state we can't operate the same way. So I guess what I'm trying to connect together in my mind as a non-expert, isn't that essentially what managed care is about? Isn't that essentially what one of the main elements that a managed care brings to bear?
I think that's certainly a core component of what they bring to bear. A managed care organization would also tell you they also bring quite a bit of expertise and ability to crunch the data and really look at needs and manage the services better. In some cases, they pay their employees better. I think Dr. Green mentioned, you know, if we don't go to managed care for some of these populations and we're going to manage them ourselves, DHS, I'll just tell you, we're going to have more capacity to do that. We do not have the strength in our staff and the numbers at the right levels to do what a managed care company can do in terms of making sure that the resources are used wisely. Now, the downside of managed care, obviously, is you're paying somebody to do that. There's a cost to it. But that independent assessment, every managed care company will tell you, yes, on the not on everybody, but on the more expensive clients, we've got to do an assessment and see what they really need.
Senator Chesterfield, you're recognized for a question.
Yes, thank you, Mr. Chair. I had asked Mr. Robin Rivendin about our exploits into managed care, and he alluded to the fact that we had done that for mental health. Could you tell me who was in charge of the managed care, and is it possible for us to visit with them about what happened with it?
You're talking to him.
Okay.
I was director of behavioral health at the time. We moved to
You're
manage.
the little rascal, huh?
It's me. We moved to managed care, and I think we actually implemented it in about 1999 with the idea of trying to manage the services better. And I'll just tell you, the provider that we got, who won the contract, about 6 weeks into it, it wasn't 9 months, it was literally a few weeks into it, they were doing so poorly by our foster kids that I canceled the contract. And we caught a lot of heat over it, but we told them up front, if you can't serve the most vulnerable children, right off the bat, you're going to have a problem with this, and they didn't, and I eliminated the contract. I will tell you, that was 16 years ago.
Okay.
I think these companies have gotten much more sophisticated, and probably more importantly, states have gotten more sophisticated in how you monitor, how you set up the RFP. I mean, you've got to do it well. If you simply hand the money to a company, you're going to get ripped off. There's a high likelihood of it. You've got to say, here's exactly what we want. You've got to have the monitoring in place, so we'd have to build some of that capacity. So I think it can be done well, but the first time around, it didn't work.
Okay. So what have we done that's so great now that makes you more comfortable with it, or it seems to me that you seem a bit more comfortable with it?
Yeah, the two things. I'm more comfortable with it in that I think the companies have gotten better at it, and states better know what to ask for now and how to do the oversight to ensure that you're getting good bang for your buck. I'll just say the second part of that is I'm more concerned that we've got to do something, and we have worked for at least a couple of years in some of these key areas. And for example, in the area of mental health, I mean, we had a proposal that was worked on for a couple of years with provider groups and stakeholders. There wasn't absolute consensus on it, obviously, but right now we have nothing from that. And I just think we have to do something with these high-cost populations. So I'm not saying managed care is the ideal way to go, but it is one way to go that I think we have to consider.
All right, thank you, Mr. Seelig. Thank you, Mr.
Sure.
Chair. I appreciate it.
Thank you, Senator. Representative Ferguson, you're recognized for a question.
Thank you, Mr. Chairman. Talk to me just a little bit about the assessment tool that we're using now. And did you say that that's completely up to the state, what assessment we use, or is that driven by CMS, or are we subject to litigation if we use a less definitive or more definitive assessment tool?
The state can generally choose its assessment tool. I mean, I think the federal government would want to say, yes, we're comfortable with that one. The one that we have proposed to use and are starting to use across the department is the Inter-AI assessment tool. It's actually an internationally developed tool that the nice thing about it is it can work across different populations. It's not just for behavioral health, not just for DD, but it actually is kind of a suite of tools where there's a core component of the assessment and then different pieces for different types of groups. We use it now in the aging population. Director Cloud can speak more than that if you want to, but that is the tool that we would propose using and that we've been working on to use across the population. Because part of the issue, as you know, is we've got people who have mental illness and a developmental disability, or mental illness and a physical disability, and they're all aging. So to be able to track them and work across these populations, we think is important.
Representative Sullivan, you're recognized for a question.
Thank you, Mr. Chair. I understand the concept behind the independent assessment. If that's true for these fields, why wouldn't it be true for all medical fields? And if we're going to have significant savings by having an independent assessment in these selected areas, why wouldn't we expand that and have an independent assessment for every physician, for every diagnosis?
It's a good question. I would say, just off the top of my head, if there are other costly populations who are also long-term populations, not someone who was in a car accident or short-term stay, but a long-term expensive population, we probably should look at whether we need to, if we don't have one already, at whether we should have an independent assessment for those groups also. I don't know if you have populations in mind outside of these three high-cost populations in terms of the amount of spend we have, but I'd be open to talking about it.
Well, I mean, people go to the dentist regularly. They see their doctor for heart conditions regularly. They see, if these high-cost medical conditions that people go to on a regular basis, it seems like there would be an equal need in all these areas if the cost savings is there. Thank you, Mr. Chairman.
All right, Senator Cooper, you're recognized for a question.
Thank you, Mr. Chair. A lot of what I'm hearing today is I would characterize as quality control issues and seem like those are ongoing now.
Yes, sir.
A couple of things I'd like for you to address. Number one is your projection for where we're going in the future and where you see it. What kind of cost savings do you see? Have you run any data on the actual numbers of that? The providers said they had a plan to save $30 million. But also another thing that's concerning to me is there's so much substance abuse that's in all of this. And I saw earlier today something concerning the exploding heroin use, which is going to make that even worse. And apparently the sanctuary cities are pockets of distribution for heroin that's coming across the borders now, and that's going to be distributed into every state and every city. And I don't have a warm, fuzzy feeling to how we can project that in the future. So would you address those for me, please?
Yeah.
Thanks.
Yes, and I'll start with the second first on substance abuse, and just say up front, I'm no expert on substance abuse treatment, but I am extremely concerned about it. We don't have a strong substance abuse system in Arkansas, in part because we really haven't paid for much substance abuse treatment. There is federal money that comes in. Medicaid traditionally has not paid for substance abuse for adults. We did start paying for it for pregnant women and kids a few years ago. And so we have a few substance abuse providers out there, but not many. And one of the things that I think we have to do a really good job of is determine, as we try to do more substance abuse coverage, and I think we're going to have to with Medicaid, is really figure out what do we want to pay for, what's really proven out there in terms of cost-effective substance abuse treatment programs, because there are lots of different ideas on how to treat substance abusers, and you can spend a ton of money, particularly if you try to do it all inpatient. What I've read is there are some effective outpatient programs. I think we're going to have to do that. In terms of our savings, our general projection across Medicaid is if we do the types of things we've talked about, in some cases, episodes of care, certainly the patient-centered medical home, which we think is very effective, and we're actually going to, hopefully, we should very quickly be able to announce some of the awards that we're going to give to physicians who have done well managing care. We think those are working well, but as the Stevens Group has pointed out, in these high-cost areas, we've made much less progress. If we implement the programs we've talked about or managed care with these high-cost populations, we think across Medicaid as a whole, we could probably save 2 or 3%, trying to be conservative compared to what we would have otherwise spent, which doesn't sound like a lot of money, but that's tens of millions of dollars every year in state general revenue, and it's cumulative, like the growth, it's like compound interest. So it makes a really big difference. So we think there are significant savings to be had, but you can't really get them if you don't deal with the 75% of your costs, which is with these populations.
Senator Sanders, you're recognized for a question.
Yeah, thank you. And I agree with my colleague back here. He was in the basement of the Capitol that day before he was my colleague, and in addressing some of these issues. And I think they had some legitimate concerns about the agency's ability to pull some of this off. But I think what you just discussed, and I'm looking at John and Richard here too, I mean, if there is an overall strategy within DHS, within Medicaid, to say I don't care where you're at, I don't care what line, which business line you're in, if you are, in our top 200 cases, or maybe we'll just do top 20% of high-cost cases. And John, we were supposed to be working on this, not just an independent assessment, but literally you're in a track where you're constantly being reviewed, almost on maybe a monthly basis or what, because I mean this is where all the cost is being generated. And I think what we've done is a good job of sort of rebalancing the organization and getting some things, or trying to rebalance the organization to focus on the right things, but we've to the neglect of where the big spend is. So the return on investment in investing in that type of policy would be huge. And I would like, John, I'd like to see a little bit more about that. And again, I know sometimes it's hard you're talking about independent assessment within the confines of CFCO. My concern, again, so my question is, my concern all along has been that once you do this, we're talking about taking, and Craig, chime in, because you've been a part of this discussion before you were at the agency. Once you take these waiver programs and fold them into your state plan, we are essentially creating, by definition, an entitlement for these. And I know that the state plan amendment that we had submitted to CMS before was kicked back to us because we wanted to do a little bit too much customization within the state. So, I mean, the concern is, and again, if you read the Federal Register, and we're talking about creating an entitlement, and that dividing line is 150% of federal poverty. I mean, our intentions could be good, and our intentions could be right, but we could find ourselves in the future in a very precarious situation. And this is why a lot of the other states, and we've talked about this, have not pursued CFCO because of all sort of the unanswered questions and the sort of the potential risk that is out there in the future.
Right.
I mean, that's legitimate, is it not, John?
Yeah, it is. I mean, there is clearly some risk with community first choice option, no doubt about it. And that's why I said, I mean, certainly without the independent assessment, you would not want to do it. And I think looking at some of these other states, there may be some controls that they found, the ones who are implement, that we'd say we'd want to use those controls also. That the risk on the other side for us is, and it's actually on this slide, I think, is that we've got now almost 3,000 people on a waiting list. And there's just every attorney you talk to says there's a really good likelihood that we get sued. And if we do, then we're going to be paying 30% match to serve all those people anyway.
I'm looking for our attorney whose name always comes up. But we haven't been sued.
We haven't, that's
and,
right.
And I think part of that is, and this morning we talked about how even if you're on the waiting list, we have people who are getting services. And again, I've talked, and I see a number of these, the families that are out here who are very passionate about this issue. And I hear you and I understand. But I also talk to people who are on the waiting list who say, we have people who are currently getting services now that, quite frankly, they need to be assessed because, quite frankly, they don't need to be getting that level of services that they're getting today. So, I mean, talking about right-sizing the environment, the question is, before we go off and throw all in the CFCO, and listen, from a budgetary standpoint, I understand, we're talking about enhanced match, but the truth is, I think we need to do a better job of assessing, one, the people who are getting on the waiver today, who are getting the services, and I do appreciate the fact that, these people are getting services now. They may not be getting the waivers, but they're getting some level of services. And to be able to look at that in black and white on a single sheet of paper will certainly help us out as we begin to deliberate and make some decisions and recommendations. And ultimately, we think, pass some legislation on this.
Representative Gray, you're recognized for a question.
Oh, thank you, Mr. Chair.
Push your button again. I messed it up. I didn't let Phil do it, which is the smart way.
All right, thank you. Mr. Seelig, Director Seelig, you said, I think I heard you say 2 to 3% savings is what you estimated by going to CFCO.
Well, not going to CFCO, kind of the reforms in general that we've been proposing across Medicaid. So that's CFCO. We actually, as you can see on the slide, we actually estimate that we'd save over a 10-year period just in state general revenue over $300 million.
Okay.
Again, I wouldn't say the figure's exact, obviously, but it's a big number.
Well, and I've got some data back from like 2013. When I look at ACS, there was a 2-year growth trend of about 5%. And the total expenditures, I guess, per person were like $43,000. And we've got approximately 10% more people that are on the waiting list. And it's also my assumption that those 10%, say 4,000, I don't know if it's, the last number I heard was 2,800, I've heard 5,300. Right. Let's just assume 10%. So 4,000 people on that list, some of which none of them have been assessed. They're all receiving services. As far as the only difference I can see is they're not getting the payment for their family member to take care of them at home, like those that are actually on the waiver. But my question goes to the savings. If, let's say we put those other 10% onto CFCO, and we have no caps in place, there's nothing we can do to control costs because we're now on a plan instead of a waiver. Tell me your logic and how we're actually going to save money when we put an additional 10% on the most expensive program we have in the state.
So it's actually more than 10%. Here's where the savings is. We have about 4,000 or so people on the waiver now. There's another 2,800 waiting, so it's
50,
60%, right. But with Community First Choice, you get the 6% reduction, which for us is a 20% reduction in the state spending, not just on those people who are waiting, but across the entire Community First, everybody who's in that program. So all the elderly and physically disabled who are currently on these waiver programs who would be under CFCO, it's a huge, because we spend so much on this population, even after you serve these 2,800 people who are waiting, by our calculations, and account for some woodworking effect and some inflation and kind of the other things we could take into account, even after you do all that, because you're putting up 20% less state funding on every one of them, you still come up with this state savings. The 6%.
I don't agree with you. I need to see that in writing. I've got 6%. I've got the most expensive population in the state of Arkansas, and you're fixing to double it. And here we are trying to cut costs, and I have no way to cap it, and you're telling me it's going to save money?
Well, so you won't. But the total population under Community First Choice, you're not doubling. That DD piece, you're increasing by 50 or 60%, but the total population, you're not. They are the most expensive, that total population, and you're cutting your cost on all of them by 20%.
But we're also giving them unlimited benefits to every single person in every class.
You're not giving them unlimited benefits. There's a defined number of benefits they get, and as we pointed out, and we would assess them to make sure, and some of the current clients probably would not get as much as they're getting. We'd assess each of them, current and future, to say, what do you actually need? And that's all we want to pay for. As I said, if we can't control this program, if we don't have the right controls in place, we don't think we should do it either. But we think with the right controls, we actually can save money. The independent assessment and CFCO would have to go hand in hand. We should not expand this program if we can't control the cost.
Okay, and then one last question, Mr. Chair, and then I'm done, but, you know, based on recent, failing to monitor contracts, through DHS, I don't have a lot of confidence that the state or DHS in general could manage and oversee any type of managed care company. How do you propose that you would make the changes in DHS if we were to go with managed care to actually do something
Yeah,
right?
if we go to managed care, we think you would have to combine, I mean, to your point, we would have to combine that with a unit, probably in Medicaid, that is specifically built to oversee that contract. That's what states who do managed care do, who do it well. They have experts, and what they do is they oversee the managed care company. I would not say, let me just do it with kind of, with the folks I have now, kind of other duties assigned. I think we'd probably fail if we did that.
Oh, I'm just so frustrated because I feel like we have enough staff in DHS that if we had the right staff and, pardon me, the right management, that we could manage this ourselves.
Well, there are staff, and there are staff we would not need if we went to managed care in some areas.
Would we still not have to audit managed care and then hire more people to audit? We've got to oversee, we've got to audit.
There's, I mean,
We
you would.
can't handle a contract right now. We can't even get deliverables on a contract right now.
You'd be,
Sorry, I'm done.
that's fine.
I think I made my point.
Senator Chesterfield, you recognize for a question. Is that any rumor? Senator Sanders, you're recognized for a question.
So I said, it's
That
I'm
did it.
gonna ask. Again, I mean, I think the important thing for the conversation is this. At some level, there has to be some type of independent assessment. And again, you know, I'll echo Representative Gray. I mean, we all have our concerns about the ability to pull off. And again, we have been doing a lot of things in this state for a while now, be it episodic payments, be it payment reform, be it the private option. I mean, people have, limited bandwidth. I know Craig's eyes have been opened dramatically since being over there, and I'm glad, Craig, I'm glad you're there. You're doing a fantastic job. But, I mean, I think what we need, and I guess John, Richard, y'all are gonna recommend, I mean, we need to be able to see, you know, I think we could still get, without going CFCO, I think if we had an independent assessment, truly independent, someone who's not incentivized, because I think one of the behavioral health providers, you know, he's right. I mean, we need to do our dead level best to make sure whoever's doing the independent assessment is not how some incentivized to arrive at a certain outcome, right? But, you know, we use evidence-based medicine, and be careful on how I use that. But evidence-based practices, those things that are within the sphere. I mean, I think that's what we don't have to go all in on one way or another. But I think just if we had an independent assessment that was, are you prepared to say what you think that might save the agency without going with CFCO or any of those other things?
Well, and Senator, let me say, CFCO is one avenue, one tool, one that from our assessment we think makes sense. But I think more important is that we manage these programs well and that we serve some of these clients who are waiting years for it. If there is a better approach, and the Stevens Group has talked about there might be some better approaches, we're open to talking about it. I mean, we want to focus on the outcome, not necessarily the tool that we use. So if there's something better than CFCO, we're very open to it, but we felt like we need to at least talk through it.
Representative Bell, you recognize for a question.
Thank you, Mr. Chair. I appreciate the indulgence, not as a member of the task force. Just two things that I heard in the discussion here over the last couple of minutes that really concerned me. Director Seelig, you mentioned that we would cut costs by 20%. And the fact of the matter is, my children and grandchildren and every Arkansas citizen is still on the hook for federal dollars. And we're in fact increasing spending to decrease state spending slightly. Is that not correct?
Well, we think we'd have significant state savings. There would be added cost, total cost, some added cost, but we also think we would, doing this in partnership with things like an independent assessment and the other controls, that we would make better use of the money that we are spending.
And I don't want to belabor the point, but I think the other representatives here have made it pretty clear That's very difficult for us to believe, coming from an agency with the contract administration record that your agency has, sir. And I'll just drop it at there. Thank you, Mr. Chair.
Senator Raper, you're recognized for a question.
Thank you. John, I was trying to look back here a little bit at some of the presentation from earlier, and I've got one concern, which I think has been maybe articulated, so I don't want to plow the same ground, about what is our capability to actually administer the CFCO, given the fact that we've had other eligibility issues and problems with verification, and maybe even either two of the gentlemen at the desk there with you have any comments on whether or not this is something we actually could pursue. And I want to leave that at that. The last thing I want to talk about is the entitlement part. But the first thing is I am very concerned, which is echoing what I think Representative Gray said. So what is our capabilities?
If I may. Keep in mind, Community First Choice, if we were to pursue that as a state, it's really a funding mechanism. It doesn't have any technical requirements beyond what we're already doing with our current programs. So, I mean, while we would like to improve and have better IT systems in place, and as John says, the assessments, we're already working on those for the DD population, the independent assessment, which will eventually, we're hoping in the next calendar year, assign resources to an individual based on needs. So that, we're hoping that would run concurrent to CFCO or any other solution we come up with to try to serve this waiting list. So CFCO itself doesn't really put any additional technical burden on the agency. It's just, think of it as a funding stream.
Okay. Well, while you're speaking, and I want to ask of each of the other two there, why is it that with only 6 states wanting to pursue this, and the fact that this creates an entitlement now, why would we want to pursue that when basically the whole nation is turned down going for it?
Well, I can't speak for all the other states that have chosen not to. We looked at our numbers here in Arkansas, and based on our population, the number of folks we could serve through this program, the number of folks we have waiting for services, it made sense. Other states might have a waiting list that is so large that the numbers wouldn't add up. So
Is it
just
really come
happened to
down
work.
just to the opportunity to gain the 6%? Is that where it's really just come down for the department?
Well, I mean, finding additional funding is yes, that looks good. There's not any other pocket of money lying around out there that's being offered. So yes, that was certainly an incentive.
Okay.
Senator, and I may echo, I definitely, concur with the concerns and sentiments of members of the committee today, and I know also to concur with Director Seelig that obviously programs such as this, it boils down to eligibility. And then when you look at those eligible under the state plan and under the Community First Choice option, you must serve all of those that are deemed eligible, which is the entitlement component, and the fact that we would not be able to establish limits. So to that point, and to concur with Director Seelig, in terms of moving forward, whether it's with this program or another program under 1115 that John Stephen and Richard Kellogg have talked about, we must still have the ability, number one, to manage the eligibility on the front end, determine that we have the ability to properly assess these individuals, assure first, based on the assessment, that they are truly institutional level of care, and then in turn, we must have the ability to determine that need based on the result of the assessment and then allocate those resources. And obviously, with this system or any other system to make that work, in order to make that work, we must have the ability to determine, number one, eligibility, then be able to assess the need, and then allocate resources based on that need. And I know that all of us here, I'm sure, will concur when we look at our system in the past, we look at the waiver that Representative Gray talked about and those receiving services. While we want the most vulnerable among us to receive and have access to services, at the same time, since we are stewards of those dollars, we want to make sure that they're being allocated appropriately. And with this program, as Director Seelig said, it's important that the proper controls be in place, because as a result of determining eligibility and those that would be eligible, you have to serve all of those people in that classification. And to ensure that you met your savings and your parameters, we have to make sure that those services are allocated appropriately based on that need, to ensure no overutilization of services in that area. But I might add that we must do that in any component that we enter into.
Thank you.
Senator Chesterfield, you're recognized for a question.
Thank you, Mr. Chair. I misspoke. I do have a question. Could you tell me who's going to do the assessments? And what credentials will they have that will allow you to know that when they do the assessments, they have done them properly? And finally, how will you track that?
Senator, in our division, Division of Aging, we're one of the first divisions that began assessing our populations in the home and community-based environment, specifically our adults with physical disabilities, as well as our elders' choices. We have a
So you
staff.
guys are the ones who are doing the
Yes,
assessments?
ma'am. We have a staff of nurses within our division that are situated across the state, and their responsibility is to administer the inter-RAI and then develop the plan of care. However, with the current model that we're working on, the AR Choices model, which is a combination of the Elders' Choices and the Alternatives with Physical Disabilities waiver, a key component of that is the ability to allocate resources and determine a RUG level and a payment level based on that assessed need, which we've not had the ability to do. And again, as we move forward in whichever mechanism the legislature and the administration and the department that we choose to work together to move forward with, that is a very critical component that must be in place to allow us to ensure that we are not over allocating resources, but also at the same time that we have the ability to justify services and ensure that they're based on need and that they're reimbursed based on that assessed need.
All right. I'm going to turn the microphone over to my friend who has a follow-up.
You're recognized, Senator Rayburn.
Thank you.
Mr. Brader, I want to make sure, have an opportunity to clear something up because I don't know if I quite heard you correctly. You stated that this was only a funding mechanism, period. And I just want to make sure I've got that clear because I think that actually there's some additional things there regarding technical requirements by the federal government, including universal assessments, and I'm being advised here that 6% can't be used for any administrative oversight whatsoever.
All right, let me clarify what I said. I still stand by that. There are no additional requirements put on us in terms of us determining eligibility. We've already got a company that we contract with to do these assessments. We're working on developing that, getting it into our current waiver. That waiver would have been what those services would have gone to Community First Choice had we gone that route, or if we do in the future, we will. So that's what I was referring to. DDS has its own eligibility unit that determines eligibility. And so when you asked the question, I thought you were referring to whether we would be able to keep up with whether we had ineligible people getting services and things like that. It would not change how we operate, and we already take care of that within DDS for our population. I'm not talking about the private option folks.
So let me restate it to help us both. Maybe it's better said, would you agree that if you choose the Community First Choice option, it is not just a matter of the funding that's involved. There are real strings attached to that with the federal government on how we manage that.
I wouldn't want to imply that that wasn't the case. Absolutely. I'll
Right.
agree with you with that.
And
Yes.
specifically, it is now an entitlement, and now you will be able to pay that money to individuals and not just providers, correct?
I think
Under
you
that-
might be
under that
referring to.
program?
I think you
I
might be
believe it's in
referring to
in
the
writing.
self-directed model, which Community First Choice requires. Yes,
Okay,
that's
all
one
right.
of
I
the
just
two
want to make
models
sure I'm
required.
clear, especially for those of us that are about to have to start making some decisions on the task force here, that we understand this is not just a simple thing where we can go back at the end of the day today and say, we're going to save 6% on this suddenly, and that's going to be an opportunity for us to save money. No, there's some real changes involved if you end up doing this. What I haven't asked, and I will, this is the last part of this, is that let's just say that we decided to pursue CFCO. How do we get out of it? Especially since it's now creating an entitlement. Is there any way to get out of it? Especially since there's only 6 other states that are pursuing it, and perhaps we find out it's not definitely what it was cracked up to be, and now we're on the hook with this entitlement. Is there a way out of that?
Yes, sir. It's a state plan amendment, and you could amend your state plan later to get out of it. But short of getting out of it, you can also, I mean, we would want to look at, would we want to limit the services that people are eligible for, change the assessment? I mean, there are different tools we'd want to use to help manage the cost also.
All right. Representative Ferguson, you're recognized for a question.
Hello? Oh, thank you. I just want to make sure I understand, this might be a better question for John Stephen, but if we went with an 11-15 waiver, would there be any chance of getting the 6% additional match, or is that off the complete, not even worth asking for?
And John may have a different, our understanding is the 6% is tied to community first choice. So I mean, you could ask for it, but I'd be very surprised if they gave it to you short of doing, I mean, the trade-off the federal government has given is saying, if you want the 6%, for everybody who's now eligible for nursing home care, you've got to make them eligible also for community-based care instead. And I think that's the trade-off they're requiring.
Senator Cooper, you recognize for a question.
Thank you, Mr. Chair. With all the problems that we've had on the EEF verification system and the contracts associated with that, what are we about to get into with the assessment of the CFCO? Are we talking about other contracts, and what's the turnaround time on getting that done? And what's the complexity of actually doing that? Thank you.
So let me speak to the EEF quickly, and then I'll let Mr. Cloud speak to, because he's working on it with the Concentrix contract. EEF is to determine whether you're eligible for Medicaid in the first place. So this would only come into effect, anything to do with CFCO would be after that. So there's actually no connection between those two. Then there is a contract we've been working on. I think that things have gotten much better. We struggled with it because it was a new item, but I think Mr. Cloud can speak to where we are on that, the assessment contract.
Yes, sir, Senator Cooper. Obviously, with the universal assessment as it's administered, there must be a portal or an instrument that's in place that allows us to process those assessments, hold the data from those assessments, as well as ensure that we can provide an appropriate level of care and then also attach an appropriate payment level to that level of care. And I recognize, as Director Seelig has said, and as we've testified here on many occasions, that there have been some issues with the system. Our current contractor, while we know that there have been delays with that contract, but I'm happy to report that they have made some significant progress over the past several weeks and months with regards to the building and establishment of that portal. However, I must add that in the next few weeks, the next steps of their progress are very critical to ensure that that they have the ability to, to round third base and actually approach home plate and finish the product. And I know that our staff and our division are working closely with them, providing the monitoring, the oversight necessary to ensure this. But to your addition, whether CFCO is the mechanism, and again, obviously, it's important for the legislature, the administration, department, as we work together and whatever instrument. I have to impress that the universal assessment, the ability to conduct that appropriately, fairly, impartially is critical to whichever approach, because it's critical to ensure that all individuals that we serve are treated fairly, and that we have the ability to determine that need and then allocate resources based on that need. And with the challenges that have existed, I feel I'm confident and I'm very encouraged with the progress that we've made, and hope that over the next few weeks we can continue to make the progress and discuss the potential go-live date for those assessments that we have been conducting.
I didn't hear you say how that's related to CFCO.
Well, with Community First Choice option, obviously the universal assessment is a requirement of the Community First Choice option, but I might add that with the waiver that's being renewed on the aging side, the Elder's Choices, as well as the physically disabled waiver and the DD waiver on the DD side, all have a component requiring a universal assessment as part of those renewals. So irregardless of the direction, it's critical that we have the ability, number one, to conduct those assessments appropriately and impartially and fairly, but also that we have a universal platform that allows us to house those assessments. And that's the product that we're working on to ensure that we have that, so that we can store that data, as well as determine the needs based on that data that's inputted in the system, and then in addition attach a RUG or payment level based on those assessed needs.
So if we went this way, you're saying you have the means to do that now, or you will have?
Well, with the direction that we're making, obviously, there is some steps. We've not actually, made it to home plate yet, but I feel that we have made tremendous progress. And over the next few weeks, it's critical that we meet several benchmarks, several parameters that we've set to ensure. But I am encouraged by the progress to date. But before I'm ready to completely sign off and say, thumbs up, I want to see the contractor perform on these issues that we are identifying that we're working on. Had a meeting yesterday at the department with our contractor, Concentrix, as well as Northrop Grumman and Cognosante that are working on behalf of the department to provide IT oversight and management to ensure that, that we are taking the steps necessary over the next few weeks. Again, it's critical that once we integrate the aging population, that we be able to do so for the remaining parts of the populations, because the original universal assessment tool, when it was set up, was not only for the aged and physically disabled, but also for our developmentally disabled and our behavioral health populations as well. And it's critical that we be able to move in that direction, in my opinion.
So are you saying that's going to be a real-time basis going forward?
Yes, sir.
Okay. Thank you.
All right, well, thank you very much, Director Seelig and team. What I would encourage everybody, I know CFCO is a very big issue. We're not done talking about it today, but make sure you get your input to John Stevens and his team. And I understand that, speaking to the committee is important, and we're going to do as much of that as we can before we end at 6 p.m., but anybody that feels they didn't get to say everything they want to say, if you send me an email, I'll make sure Stevens gets it if you don't have another way to make sure that happens. So we're not trying to shut down anybody's voice, but we're just going to be managing the time. And as we're starting to land the plane, we'll continue on the agenda that I mentioned before, where at 4 o'clock, John, if you and your team want to come down for item K, for those of you tracking on the agenda, that's the last item that we're going to let John go first. What I envision happening is, let's say it's 20 to 30 minutes of item K, then we'll go back and pick up 20 to 30 minutes on item F, and then that will leave us about an hour for the folks to speak for and against CFCO. So that's kind of how I'm envisioning this going till we hit our 6 p.m. end time. John, you're recognized for item K.
Thank you, Mr. Chair, and I'm going to be real brief, conscious of your time. And my team is here if we need to bring Richard or Stephen up. But this item was really to give you an idea. The last meeting we had, there were a couple items that we needed to do some further research for you, and we did. And then then I want to give you an idea of the overview of the final report, so you know what to expect, what's coming. The first issue was, when we left the meeting with the managed care companies that were presenting, there were a number of you that thought there was a few questions you wanted answered. There was one involving, did any have any involvement in litigation recently, fines, penalties? There was a question about bending the cost curve, which I thought was a great question. So there was one other question, if you bent the cost curve in other states, do those include your administrative costs or not? Were they in and out? And we've done the research in a number of states. We've looked at this issue closely since the last meeting, and the responses all came in from the managed care companies. So we've added those to our grid, to our matrix that we're going to send to you in the final report you'll have, and all the responses you'll have too, so you'll be able to see what they're saying. I can answer questions if you'd like. Generally, in a nutshell, I've spoke yesterday, a long conference call with the folks in Kansas, the Medicaid folks. They were very gracious and gave me a full, hour and a half of their time. They went to full managed care 2.5 years ago, and they called it all in. The governor wanted to move to managed care for all populations. They put $64 million from their savings into the DD wait list, and they matched it with $149 million of total funds counting federal. And they still bent the cost curve at 7% down to about 5.2%. They're sending us all that information. Tomorrow we're going to be meeting with the Mississippi folks that have gone to managed care. We've spoken to the Texas state folks. We're visiting them because we feel strongly that we're going to give you recommendations. We want to be able to at least hear from the people that are at the state administering these divisions and programs. And then we're going to be able to provide to you what some of their organizational structure issues are, because I know that's an issue. And we're also looking at the states that had the primary care medical home and determining what the outcomes were on those issues as well. So that's kind of where we are in terms of the managed care framework. And then we'll be able to answer a lot of the questions post the October report that you'll see in our report. Then I want to be able to also tell you, we spoke with the agents I wanted to mention this because Representative Collins wanted us to meet with and talk to the agents in the private option that actually work on their own independently, but get a PM from the insurance carriers for helping people map through and sign up for the private option. I thought it was a very productive discussion because they wanted a chance to speak to you all, and there was just not enough time. So we told them we would relay the strong message. We're going to put some information in the report, but bottom line, from my estimation, from that discussion, which was very productive to hear, they're doing a great job trying their best to help people through this system identify, but there's a couple major issues that came out of the conversation. It is the eligibility system delays that are creating lots of problems for their clients, as well as communication and collaboration. And I believe that a large part of it is really they want to be a partner. They want to have a seat at the table and to be inclusive with any of these discussions going forward as well as past. And I don't believe, and I'll just speak for them from what I heard, that they feel that they're really embraced in terms of a true partnership. Because they are trying to help these individuals identify a bunch of questions and issues and where they go from the county office. If they can't fix something there, they're trying to contact state office. And I think they're a key player in this whatever decision you make going forward. So I wanted to make sure that was also post-August meeting. And then we've also done a lot of research on other issues. So I will now tell you about the final report. Basically, just to give you the framework, where we're working from. So our full team is out there continuing to do some analysis on data, continuing to identify areas that we really need to start working on in terms of our writing. We're absolutely in writing mode as a team. So but it does not mean, as Representative Collins said, if somebody gives us an idea and we haven't considered it, we want to know about it. And I'll contact them if we have the time, but we're coming down to crunch time. We are going to deliver a report that has basically 3 volumes, the way I see it. And this could be subject to some minor change. But you're going to have volume 1 is going to be an assessment. It's going to cover the areas of the RFP that you asked for. And it's the areas we've already identified a lot of them for you. We'll recap some of them, but we're going to be able to tell you in volume 1 all the findings, the assessment. And it's going to be rather large. But it's going to be what we see as the state here that we have addressed. But it may be a little awkward in terms of chronological order because we're trying to make sure we meet the RFP, what you've asked for. But then the volume 2 is going to be our recommendations. And the recommendations section is going to really go like this. First of all, you have two major areas. You've got the private option and you have traditional Medicaid. Everybody that I've spoken to, from Director Seelig and his staff, who's been very helpful to this whole process, as well as providers and community folks, everybody agrees you can't keep the status quo. So we're not going to give you the status quo. But there are going to be some things we may recommend that might not be part of the overall bigger solution, might be things you should be doing right away. So we want to structure the final report as private option, decision tree. Here's the impact if the private option were to go away. Your impact to your economy, the impact overall, and then we're going to say, if you were to keep the private option, here are some ideas for an alternative. Alternative within the box. And what we mean by within the box is our team is going to give you a recommendation on just thoughts. And you may disagree, you may agree, you may want to add some on your own. But that's going to be what we have seen that has been either accepted by CMS or they have indicated their willingness to at least look at that area. We call that within the box. And that's going to involve another waiver. The next component is going to be...
John, I just want to make sure that it's, and I know you and I have already
Yes.
agreed on this, but I just want to make sure that I'm really clear so the task force folks all know. In that place is where you're going to assess and include the specifics that the governor presented
Yes.
to us before.
Yes.
So that will be included, and,
Yes.
and John's point of view on that will be in there.
Yes, and thank you, Representative. Absolutely going to address the 7 points that were raised by the governor. So, and then there'll be I call out of the box, or an alternative that may involve additional negotiation discussions, maybe a longer-term vision, maybe something else you want to consider. But there are going to be options for you to look at, and at that point, you obviously make the policy decisions. But then we're going to move into the traditional Medicaid, and then we're going to do a similar decision tree. And the decision tree is going to be simple from the high level, but then it gets somewhat more complicated. I give you an example. We believe strongly, no status quo. You got to move to more integrated, full, and some risk. Integrated risk, value-based purchasing, primary care, medical home model throughout high cost. Second is your managed care. And managed care could be all populations like Kansas, Texas. It could be long-term support services like Tennessee. It could be like Mississippi, where they started with some of the children. There's a lot of different options here. And we're going to try to model financially those options. So when you look at this, and what's really important here is what we heard earlier on the assessment. I want you to be thinking about this. Because whether you go down the road of the value-based purchasing, whether you go down the road of the managed care, per se, don't think of managed care like in the 90s and when it was HMO, and it's completely changed. It's coordinated care. It's different. If you think, don't get so hung up on the terms. But at the end of the day, so is the medical home component. But what you heard today about the assessment, and Director Cloud said, the nurses go out and the nurses are going to do the assessments, and the nurses, where is the risk? Who has the skin in the game? This is what we're trying to tell you. The states around this country have seen this program for a long time now and have decided you've got to have skin in the game. You've got to have more risk. And if you do well and help this population and provide good quality, we're going to reward you. And that doesn't happen when the state does this, and it doesn't happen under the current system here. So a lot of our thinking is to give you recommendations which are more risk-based and more fully integrated. So that's
And
kind
this-
of the framework.
And John, if I could just interrupt you again, this is the part where inside of that, kind of, again, tying back to one of the things the governor kind of charged us with, the 50 million in state savings, which grosses up to 180 or 200 or whatever it is, this is where we're going to see that decision tree in order
Yes.
to deal with it.
Yes, and then the third component is going to be the test bucket areas, we call them, but they're going to be just ideas and initiatives that you may want to, look at for legislation. You may want to do something in reform your, what do we call it, the all payers or any willing provider law. We may recommend that you be more restrictive in certain areas. But whatever, it may be a big issue to someone, and someone might say, well, we worked on that law. But we're going to provide a lot of different ideas and then give you some thoughts, and there'll be some specificity, Representative Collins, as you've stated earlier, around each of those items. That's
I've got-
kind of the framework.
John, can I interrupt you? I've got a question from Senator Cooper.
Thank you, Mr. Chair. Over here.
Yes, Senator.
One of the things that I'm very concerned about is systematic quality control. I've talked about that several times today, and it's been part of this discussion. And are you incorporating anything into your final report or anything in your preparation about in-house quality control as we go forward? Because I'm afraid whatever we do, if we don't have a form of quality control in the DHS system itself, that we will lose whatever savings that could be there.
Yes, Senator, thank you for the question. Absolutely, and it's going to be dependent upon making some very important decisions on your part, because there's going to need to be some administrative changes
As
in terms
Mr.
of-
T said in Rocky, I predict
Yeah.
pain. I predict pain.
Yes, to answer your question, yes. But I think it's important, it's important, though, that we also look to what other states have done that have been successful. And Richard and I were in Tennessee last week, talking to the directors in the department. And we were very impressed with the way they operate their division. And it's operated, they mentioned, like a health plan. And they showed us the structure, the divisions, and how it's working. And we really liked it, and we're going to provide some examples. There's other state examples. And at the end of the day, in terms of quality control, I will say one more thing that I really think is going to be part of our recommendations that's important, is that this body begin to look at a benchmark, balanced scorecard type approach, that you are provided the data in a metric management type focus, where you're looking almost on a monthly basis of targets and where are we, and continuing to monitor this very closely, because this can fail, any reform in Medicaid, if you are not involved as well. And the final thing I'd say is, you also have to help bring some resources to the department. And we'll talk about that in our final report.
Okay, thank you.
Senator Chesterfield?
Thank you,
You're
Mr. Chair.
You're recognized for a question.
Yes, Mr. Stephen, you refer to volumes 1, 2, and 3.
Yes.
And when I think volume, I think voluminous. And one of my great concerns is that it not be so voluminous as to dissuade us from reading it in its
Yes.
entirety, and therefore missing
Yes.
the totality of what it is you're sharing with us. So as we look at the volumes, I want to know how voluminous it is, and will it preclude us from actually being able to read it in a timely fashion and responding appropriately?
I thank you for that question. I mean, we've done this a number of times, and Volume 1 will have a very crisp executive summary. I think that it'll be very helpful, and I recognize your concern, and all members of our team do. This is a very complex program and analysis, but yeah, absolutely.
I'm not opposed to reading, I just want to make
Yep.
sure that we
There
all
will
have,
be- there
that
will
it
be.
will be
Yep.
readable. All right. And finally, have you completed the report? The rumor is that the report is already done and da-da-da-da-da-da. Would you speak to that, please?
Report is done. Oh, I think what you're hearing is our scrub. Our scrub has been completed.
Oh, okay.
We are working through right now, making sure we did not get all of, as you did this contract amendment for us. Unfortunately, we requested the complete file, and the department's been great in giving us data, and any questions or issues we always work through. But for some reason, the folks at Curum didn't send us the complete private option file.
Okay. And just
so
one final concern
We're
quickly.
almost done.
All right, one final concern quickly. Kansas is underwater fiscally as a state. Is what they're doing one of those things that would be worthy of consideration for us, since they haven't been able to manage anything else, it seems?
The question is the department?
Uh-huh. The state budget is underwater. I mean, they're needing money, they cut all the taxes in the world and cut the income of the government so vociferously that they are underwater. So I'm just wondering if we can rely on what they're saying in Kansas, or is that a reflection of that
I mean,
department?
I think that we will have some recommendations that will
That are
help you.
Kansas-based.
Well, other states too, but
Okay.
will help you in that area, I believe.
Thank you. Thank you, Mr. Chair.
Yes, ma'am. Representative Flowers, you're recognized for a question, and I apologize that I didn't get to you faster since you were in the queue from before lunch.
Oh, that's okay. I had a good lunch, so I've been waiting very patiently.
Oh, there-
I do appreciate being able to ask a question outside of the membership. And so I also ask you to indulge me, because my questions, and I do have 3, if the chair will indulge me.
You're so indulged.
Thank you. That are really relative to my maybe observation and perhaps even concern that the focus or the name even of the task force is healthcare reform and not just Medicaid reform. And I was hoping, as we've had conversations, and I know you all joined us for a forum discussion we had in Pine Bluff, and a lot of really important issues that are sort of beyond just Medicaid have bubbled up that, but I haven't heard a whole lot of that in these meetings. And so one of them that was touched upon when you all delivered your report, I think like 2 meetings ago, was about care coordination.
Mm-hmm.
But it seems like in terms of some of the high cost Medicaid expenses, and even just care across the board, care coordination would be really important. And I haven't heard anything about community health workers, how or whether or not that's being strengthened in a way where we could rely on them to be a part of the process to ensure quality as well as cost savings. And I guess if I can just go one by one, that was my first sort of question and concern. Will that figure prominently in the report to give some recommendation or guidance as to where we go from here, since there's a community health worker presence, group of professionals, association, evidence-based research, and even some things that are happening in the state with regard to UAMS, and a very successful organization that works right in, I believe, in Senator Murdoch's district with Naomi, thank you, Naomi Cottoms, and at UAMS. So there's some stuff going on, but we're not hearing about any of that in this broader conversation about healthcare reform.
I mean, I think that community health centers, we met
Or
with
community health workers.
Well, the centers and the workers are absolutely a part of this integrated care coordination model, and it will be part of our report to talk about the importance of community health. It underlines a lot of the discussion we've had, because it's all about integrated care models, coordinating care in the communities. But understand that the FQHC model itself, which is very well respected and well known and needed in especially in some of the areas of the state here, whichever recommendation you move towards is going to impact that in what we believe a positive way, because they're going to be part of both of them in a very, very major way, because they're part of that community fabric. So yes, we had planned on going to one more site visit with community health. I don't think it's going to happen until after October 1st, but we had a very lengthy discussion. We've got a lot of documentation on the impact as well. With regard to UAMS, I think that there's a lot of good things going on that they're doing too, and I just last week met with Dr. Ram, and he had given us some thoughts on his idea of population health. And remember, the private option, one of the sections that you've asked us to look at too, is involving the population health of your state. And we like where he was in terms of best in the SEC and his thoughts. And that's something that really resonated with our team. We were in Chicago last week doing all of our team meetings. And we fly there because that's where one single airport, it only takes one flight, not 2 flights. But we're all talking about this very issue. So it'll be in the report, because no matter what you do, we want you to be best in the SEC in terms of health. And health disparity is a part, and Senator Chesterfield's been really a big advocate of those issues. We have a section in the report that we're going to be writing about on health disparities. And we've got some data, and we're going to show you or talk about some of those models as well. So yes, but again, we're responding to what I think we were tasked to do. And, we can't hit everything everywhere. It'll be more than just voluminous, but it is going to be addressed.
Okay, thank you. And I just would...
Thank you for the question.
Sure. And I guess the other thing, I'll just limit it to 2. The other thing, because I think I'd like an opportunity to kind of do a sidebar and maybe share some information, because the way that you answered the question, it doesn't specifically address exactly what I'm talking about, so I
Okay.
don't want to go back and forth, but I'd love to share the
I would like to.
information that I have with you. The other thing that we've heard a lot about is prevention, and we heard a lot from, and we've heard a lot even before this process began about how healthcare outcomes, especially being where we are in the country in terms of the health status of our state, you know, we know that there could be cost savings with regard to moving from a, as Dr. Elder says, a sick care model to a real health care model. And I'm wondering if your report will touch upon prevention, healthcare goals and incentives as a cost savings measure, as well as a mechanism that can help move us again away from a sick care model to a healthcare model.
I mean, we're going to address overall utilization. Again, when you talk about prevention, preventing a lot of the additional high-cost episodes, allowing for better quality care at the front end, it's all within the framework of what we're going to be addressing. For example, when I talked about Kansas, you know, we talked a lot about the reduction in improper utilization of emergency rooms. They've done a good job there. There's a model in Texas. All of this is about prevention. It's a diversion program in many states. We're going to talk about nursing home diversion. And, you know, when you talk about prevention, it's a very broad, you know, as you know,
Yes.
global issue.
Yes.
But we are going to have aspects of it within the recommendations. And we can talk more about what your thoughts are, because I'd be interested to hear what you would like us to make sure we consider.
I appreciate that, and I just would end with this point for my colleagues who are here and the others in the audience. A lot of the money that we spend in treating illness, especially with the top mortality and morbidity causes that lead to what we're spending money on, especially in Medicaid, there are root causes, and I know that we probably maybe don't have the time and the resources to deal with all of it here, but I just would caution all of us to think about how important this opportunity is for us to really deal with this as healthcare reform and not just Medicaid reform, and focus just on cost savings, especially cutting mechanisms, when we could look at what communities could do with a little resources and a little bit of prevention. And we know that for whether you're talking about cancer, diabetes, hypertension, heart disease, what we eat and what we put in, what else we put into our bodies, and how we move our bodies have so much to do with what causes disease, and also how disease can be effectively treated, especially diabetes. So I just would throw that out there and think about how we could really be creative and think and operate outside of the box. And I'll just end there, and thank you all so much for your indulgence.
Thank you. Okay.
Were you
Yeah,
done, John?
Yeah, if there's
Okay.
no other questions, I mean, we're at the point where I think it's important that, you know, again, if anyone had any further information, to make sure they get them through the chairs, and
Yep.
and Representative Flowers, I'll make sure I know Richard and you have been in contact, and either way, we're going to make sure we have another conversation about that.
So I just want to make this one time, and I'm going to do it enough so that later, when I bring it up, everyone will say, for crying out loud, you said it 100 times. Any information or any idea about any program that anybody has, if you get it to me, if you can't get it to John directly, I'll make sure he gets a chance to look at it, to consider it for his overall report. And that's a method that exists for all 3 million people in Arkansas, to get their thoughts on this into him so that it can be incorporated into the initial set of recommendations so it can be debated. So all ideas are welcome, and John has been awesome at considering them. So this is kind of my last call for that, because when he comes back and we have our next meeting on the 7th, that will not be the time for new ideas to brainstorm with John. The time to do that it would be now and earlier. So I just want to make that point so we don't have that coming, because it's going to be hard enough to make decisions on the recommendations that we do get, given the tough choices involved. Thank you very much.
Thank you.
So now we're going to move to item F, and Developmental Disability Provider Association, David Ivers, Sarah Israel, and Mike McHeight, if you folks would come down. So my goal here would be that we could get through, we've got 1, 2, 3, 4 groups that are going to talk on this subject, and my hope is we can get through this by about 5 o'clock, so we leave 1 hour to listen to people pro and against Community First Choice, and we have 15 or so folks signed up to do that. So I'd appreciate if we could be as expeditious as possible, because we are going to be ending the meeting at 6 p.m. Thank you, and please introduce yourselves and who you're with, and you're recognized to share your thoughts.
Thank you, Mr. Chairman, members of the committee, those of you who are still here, we appreciate your indulgence. I'm David Ivers with the Mitchell Blackstock firm. With me, in case you have some questions that I can't answer, are Sarah Israel, who's the Executive Director of the Developmental Disabilities Provider Association, and Mike McCrate, who is Chair of Governmental Affairs. So what we've done today is, like the other groups have given, or going to give you a short PowerPoint presentation. We're not going to go through all of it, just kind of hit the high points and hopefully
Task force members, you have that in your packets.
And hopefully we can keep within your time constraints, but if not, just interrupt me and I will stop right there. Okay. DDPA is, as you all know, the Developmental Disabilities Provider Association, represents 69 nonprofits across the state in your communities. I think most of you are familiar with many of the organizations represented by DDPA. We'd like to point out that DDPA was the first, or at least one of the very first groups to step up and tell the state that it did want to be a part of the solution. We volunteered under what was then Medicaid Transformation and then later called Arkansas Payment Improvement Initiative. We made a lot of progress. But we ran into some difficult policy decisions and also the strain of the limited state resources. More of the resources were devoted to the medical side rather than DD and the special populations. So what we've done basically is presenting you today with some of these policy decisions that still have to be made in order to make progress in this area. They will not be, whether or not you go with managed care, these decisions have to be made. And even with managed care, these are your constituents, these individuals and families, and you will hear from them, whether it's with managed care or some other model. So we all want to be part of the solution, but it's not going to be easy. So moving to page 3, what we've done is just set out there for you. We'll start out with as you know, there are a number of programs, as you saw in the Stephen Group report, for DD services. What you hear the most about is the ACS, or more commonly just called the DD waiver. And to address a question I think Senator Dismaying had mentioned earlier, and that is, are these services cheaper when you consider the provider tax, and even after the provider tax that is paid for the institutional care in Arkansas, home and community-based services are still cheaper for the state. Now, that doesn't mean that we can't do better, but we wanted to point out that waiver services are already heavily managed in Arkansas. This is an area where we do have third-party assessments. I did want to point out one thing. I think this was mentioned in the Stephen Group report. It is true that the assessments are viewed as critical in determining the right level of services. However, even with managed care, CMS says that states must use a conflict-free entity outside, so either the state or another entity, not the managed care company, has to do the assessments for both eligibility and functional assessments. So that is not a savings that you get with managed care. The state will still have to pay for those services outside of the MCOs. Another area in which DD services are managed is the tiered, which I think you heard Mr. Brader say, working on a tiered rate system based on these assessments. And then a third there towards the bottom of the page, enrollment is capped, as we all know, and service plans are prior approved. Every service plan is prior approved by DDS. The next slide simply shows you, as you've seen in the other areas, that there is a group of beneficiaries who are the high-cost, high-need beneficiaries. However, we point out that of the top 1,000 most expensive enrollees in the Stephen Group report, only 250 are DD, or what we now call IDD, for intellectual developmental disability. And of those 254, according to the data from DHS, only 11 of them are outside of the institutions in the waiver program. The chart there shows you that 15% of the clients account for 55% of the total costs. Again, many of those are clients with very serious needs in the HDCs. Now, this next slide is just some ideas on how to bend the cost curve in the DD waiver, and we point out that the patient-centered medical home is not really geared to take care of DD members, and that's, as you've heard from the Stephen Group. That is an issue, and another issue is how do you deal with that through the patient-centered medical home, or we think a better method is through a DD health home or other DD-centered model. But we would recommend that the state do, as the Stevens Group has said, and reallocate more resources to coordinate care for the high need, high cost, and at least the top 15%, since the top 10% would not capture many outside the HDCs. We also believe that community-based providers are the best suited for care coordination, which is essential for this population. The page 6 of the slides, again, is some other ideas on how to bend the cost curve in the ACH waiver, on the ACS waiver. I want to point out here that there was some considerable discussion about a 20% overhead for DD providers. It's not that DD providers are unwilling to take some different amount of overhead. The problem is, if you do that, you will then have to fully fund direct care services, which is not done today. Also, the managed care organizations will take 15 to 20% for their overhead as well. What seemed to be the issue that I heard from the Stephen Group report, which I understand, is the desire that somebody take risk when they're being paid to be accountable for these services. We have never been averse to that idea, but we want the state to bite the bullet and make some very hard policy decisions that will not leave the opportunity for anyone to game the system. In other words, everybody plays by the same rules, and you can't go from one provider who is doing the right thing to another provider who is not doing the right thing but will offer more services. So a few other ideas are that we need more emphasis on natural supports from family and friends, reconsider the heavy reliance on one-to-one staffing, which is very expensive in the waiver, and consider greater use of shared living and shared staffing. And I won't go through each of the items there. Page 7, there's other ideas. Again, very hard decisions. You can look at what North Carolina has done, and I can tell you these are not easy to do. Managed care organizations will do them. If you have 3 managed care organizations, they may all do them in 3 different ways. We would prefer that the state make these decisions, but again, they're not going to be easy ones. On the next page is how to address the waiver waiting list. I really think there's been a lot of confusion about that. We have never said that those on the waiting list are not receiving other services. However, those on the waiting list are primarily receiving non-DD services. I think Director Seelig pointed out that by both his and my calculations, we're talking about an average of about $12,000 for expenditures for those on the DD waiting list. Most of those expenditures are not for DD services. So even $12,000 would be far below what most individuals with developmental disabilities in Arkansas and other states need in terms of services for their developmental disabilities. So They are getting some services, but they are not getting their needs met in terms of DD in that area. The one idea we'd like to mention is the idea of at least a limited supports waiver. This is used in 18 other states. You set the maximum plan amount lower than the average comprehensive ACS waiver. Typically, that's 20 to 50% lower in other states. It's not a panacea. It doesn't automatically resolve all the issues on the waiting list, but it will relieve some of the pressure, and other states have found that it is a helpful tool to address that issue. Employment, on the next slide, this is an area in which Arkansas is at the bottom or nearly the bottom nationally, in percentage of persons with IDD who are employed in integrated community settings. We have only about 100 people receiving integrated employment out in the community through the waiver, and less than 100 with IDD through Arkansas Rehab Services. This is primarily, not exclusively, but primarily due to an extremely low reimbursement. Ideas on how to increase employment would be, of course, the reimbursement level has got to change. Consider the 1915I option, which the state is working on. That's one of the elements from the Payment Improvement Initiative that the state is working on, and that simply provides long-term kind of waiver-like supports for those who are in employment settings, but you do not have to meet the institutional level of care. So that would be a big benefit and should help increase the numbers. Another idea is to permit 1 to 3 instead of 1 to 1 staff to client ratio. On page 11, we have put out for you here just a rundown on the day habilitation programs known by various names. I know that these are a subject of great debate. There are 2 programs. One is the Developmental Day Treatment Clinic Services, or DDTCS, which are the nonprofits, and the other is the Child Health Management Services, which are predominantly for-profit, but not exclusively. Both offer day habilitation and along with speech, physical, and occupational therapies. DDTS includes adults, CHMS is children only. Although CHMS was originally conceived as a more intensive medical model, over time the programs have become more alike than different. The greatest expenditure, of course, is on children. So there's been a lot of talk about what to do. We have a large number of enrollees, and it is a big portion of the budget. So there's already, thanks to work that we did jointly with the CHMS Association, a moratorium from the 2013 session, or more technically, it's a controlled growth approach. Universal screening is needed, clinical evaluations with approved testing instruments, clearly defined eligibility standards, and tracking, screening, and evaluation to prevent provider shopping, and some other things you can see there. These are all things that the two associations, the associations for the 2 models have worked on and come to very close agreement on nearly everything on this list here. The next page is on just simply a pie chart that shows you that how we stack in Arkansas in terms of rebalancing and community integration for DD services. As you can see, it's a 73 for home and community-based services versus 27 for institutions. And then on the next page, you can see that that is almost the reverse of the aging and physical disabilities side, which is why we want to emphasize that DD is not the same as LTSS in Arkansas, and that it's important that if we have any discussion about managed care, how to reform the system, that we not lump everybody in together, and what approach works in one area may or may not work in another. The DD budget, the only significant rebalancing left to achieve in DD will require significant participation of HDCs. And you all know the pros and cons there, and that's a decision only you can make, not managed care organizations. So I think really what we wanted to leave you with is that with or without managed care, DDPA will work with you. However, we can't do the job without reasonable rates and a predictive rate methodology. All these changes are needed that we've talked about, or at least some mixture of them. But in the end, it comes down to, even as nonprofits, we have to be able to meet costs like the minimum wage, the Affordable Care Act mandates, and we can't do that without predictable or some kind of predictable rate methodology. We have lurched for years from one rate fight to another, and we have got to find some way to deal with home and community-based services in a more stable, predictable fashion. The nursing homes and home and human development centers and other providers, it's not that they don't deserve those, but that kind of approach where it's predictable and you know that your costs are going to be covered in the years to come, that is something that's got to be figured out for home and community-based services as well. So we will work with you on whatever you decide with or without managed care, and that's hopefully within our time limit there.
All right, well, thank you very much, and that was very informative. Task Force, do we have any questions? Okay, then thank you very much, folks, and we're going to move on to Child Health Management Services Providers Association. Amy Denton. Amy, are you still here? Yes, ma'am, you're recognized to present, and if you'd introduce yourself and who you're with, just for the record.
My name is Amy Denton. Can y'all hear me? And I'm from the CHMS Providers Association, and you should have an outline. Does everybody have an outline? Okay. Well, I'd like to thank you for giving me the opportunity to present today about the CHMS program. It is an amazing program and one that I'm really, really passionate about, but I know we have to be brief, so I'm going to go through my outline pretty quick. A lot of the stuff on here that I put is a lot of detail about our program because I'm not sure how many of you are real familiar with it. So I would encourage you to take this back and look at it, although I'm not going to go into a lot of it. I think it's important when you talk about the CHMS program to understand how children are determined to be eligible for our program. For us, therapy evaluations determine eligibility. So physical, occupational, speech therapy, and a psych examiner who tests for cognition, which would be IQ.
Could I ask you a question real quick?
Yes.
Could you just tell us, never mind,
Tell us.
Amy, you're good.
Good?
We've got it, yep.
So we test eligibility for our program by using therapy evaluations. And 2 of the 4 areas of those therapy evaluations is what determines eligibility for our programs. And that's important to know because when I talk about what I think our major obstacle is and some solutions that we have, it's going to come back to our eligibility. But I would like to point out a couple of things. Because our services are based on-site and they're community-based, all of our professionals, our medical directors, our nurses, our therapists, any behavioral health providers that we have, all get to work together, and we are able to provide an incredible amount of care coordination in our programs. And I've heard several people talk today about the great benefits that care coordination can have for our population, and we serve children birth to 21, actually. Now, I would say probably close to 100% of the kids we serve are probably birth to 5.
So Amy, so you're the first person that said, everybody said, I cannot do care coordination, I'm incapable of doing it, come do it to me, and you're telling me you're already doing it. Can you tell us what your secret is?
Well, because we are a program that has a full array of services that a child between birth and 5 may need, all together working in one program. We see each other every day. We can communicate often. We have collaboration meetings. And we don't get reimbursed for probably a tenth of what we do in terms of care coordination, but just the fact that we're all in the same building working together, along with the parents, and even along with stuff like our nurses, and I can't speak for every organization, but mine, we have 2 RNs that we provide an incredible amount of nursing services. But the reason we have 2 is mainly because they spend a lot of time talking with the nurses at the patient center medical homes for these children. So when we get to talk to those medical homes, from our nurses to their nurses, and we're coordinating care and working with these families, I'm not sure, I don't have a dollar figure for you, but I promise you that the results are immeasurable that we get to see. It's just because we are together. You're not picking and choosing little pieces of services all over the community. So care coordination is a big thing, I think, that makes our program great. I would like to talk a little bit about cost containment, because I know everybody sitting here knows that when you're dealing with infants, toddlers, and preschool-age children with special needs, that nobody wants to deny them any services. But we do understand that we've got to contain the costs, because obviously we've got a limited amount to spend. I've been a CHMS provider for 10 years, and since I've been a provider, the checks and balances you see on this second sheet, and I wrote them out because I want you to see the regulations that we are required to do in order to serve one child. So once a child is determined eligible for CHMS, the rest of the services that are provided are pretty much cost contained, other than therapy. And therapy, likely because it's not exclusive to CHMS. It can be provided independently through outpatient or other agencies. But all of our evaluation and service codes are capped. Our service codes are capped through prior authorization process. If a child is determined eligible because they qualify on therapy evaluations, they receive day treatment at pretty much about 3.75 hours a day of reimbursement, although most of us serve 6+ hours in day treatment. But they also can receive nursing services and other services, but those are not given. They can get the therapy services that they qualified for, but if we need nursing services or any other services, those too are separately documented and justified through a prior authorization process. All of our services are required to have prescriptions from the child's primary care physician for an evaluation, for a referral, for an evaluation, and for treatment, one for therapy and another for day treatment and other services. So we go through all of these checks and balances systems. Several people look at our evaluations and sign off on them to make sure that they think those children should be eligible. In addition, and I'm not going to go into, but I've put here on your outline the annual on-site reviews and audits that we receive, 5 to 6 different agencies coming in and checking out to make sure our programs are running with quality.
All right, Amy, we have a question. Senator Sanders, you're recognized for a question.
Amy, thank you for coming. We've had a lot of discussions about this. I think you do a good job. I think there's a fundamental problem with the CHMS program in the state. You discussed all the number of things, I guess the barriers to providing care, but also know that it's very disproportionate around the state when we have kids in certain counties where 50% of the eligible children are receiving this care, and this is sort of bizarro world in terms of the percentage of people or percentage of kids. This is one that has been held in place with quite frankly, with a couple of consent decrees. The CHMS program, and I think this is one I've asked John Stephen to take a good look at. Members, I sent there was a report that. I guess it's Ray. I don't know if Ray's still here or not. Ray Hanley prepared, looking at both DDTCS and CHMS, and sort of their impact and sort of the disproportionate level of care. I'll tell you, a big problem that I have is this. I've got some of the best pediatricians across the street at Children's Hospital, and we've talked about this when we had coffee the other day. And I mean, talking the best. And what has happened consistently here in Little Rock is they are losing patients because they have kids that come, parents that come to them with their kids and said, look, if you sign this, my kid gets free services. And they say, look, your kid, your child, my patient is fine. They're not developmentally delayed. You know, I don't care that, you know, you having somebody telling you that your 2-year-old should be able to put a puzzle together. Your child is fine. And then what happens is they lose their patients because they're going to go to some pediatrician who is referring to CHMS providers, and this is not good, you know, behavior, obviously. And I guess my question is, how do we deal with that? How do we deal with, because the program is pretty well open. I mean, you've got physical therapy, occupational therapy, speech language therapy, cognition. We don't do independent assessments. We don't do any of these things. It's pretty much Wild West, kind of throw it open. And we've got a number of good doctors, good pediatricians. These are people I think that pass the muster of analysis, saying, look, you've got a problem with your CHMS program. DHS has said we've got a major problem with our CHMS program in terms of it being blown open. I'm just wondering, you know, where can we save? What can we do better? I mean, you've outlined it really well. I mean, I don't see any numbers.
No, and I don't have any numbers for you because really we just started the process. I will tell you, the problem that we have in CHMS, as I mentioned, is not once the child is eligible. Everything's pretty capped. You really can't bill more than what you're prior authorized to do. But it is our eligibility. We totally recognize that that is an issue. We've identified some ways we could solve it. And I know independent assessments is one of the things. I met with Senator Sanders, asked him specifically, what is it that we need, as an association, need to be working on in order to gain the credibility that we're looking for in the state with some of the physicians. And though there are some physicians who don't understand, I guess, how we're determining eligibility for our patients, but there are a probably equal amount or more pediatricians in our state who actually do support our services. So it just depends on, and I've actually been going around and asking pediatricians to come tour. I would like them to come see actually what the programs look like so that they can get an idea of where they're referring, or if a patient comes in and says, this center told me to say this, go out and look at them, tour them, ask questions. I'll give them a list of questions they need to ask when they go out to find out about the quality of services that are being delivered, because I recognize that there are issues. I think the main issue we have, though, in CHMS is we have an incredible level of inconsistency and lack of knowledge in performing therapy evaluations. And I can say that because I'm a physical therapist by trade. That's what I went to school to be, and that's how I got into this industry. But I'm going to give you an example of what's happening right now that I don't know if people really are truly recognizing, but that we as an association want to address. For eligibility for physical therapy, Medicaid has a set of guidelines, and we go through those guidelines in order to test that child. We use standardized testing, Medicaid-approved standardized testing. I'm going to use a gross motor example. If I'm testing a child who's 2 years old and I take them through an evaluation and they fail that evaluation, meaning they make a qualifying score on the evaluation that they would need therapy, I've got to stop and look at why they qualified. Not just because they did, but why did they qualify? What I see across the board when we're talking or when I'm asking questions is a therapist will say, well, they failed the test, they need PT. And that is not always the case. What we've got to look for as therapists are impairments that would cause them not to pass the test. So they may have qualified for physical therapy because they can't follow directions, or they were non-compliant during the evaluation. I don't know how many of you have ever tried to spend an hour evaluating a toddler, but it is not easy. And in many cases, it can be to non-compliance. But I'm not sure a lot of our therapists that are out there evaluating in our state understand the difference between non-compliance or just not following the directions or failing the test versus an actual gross motor impairment that needs to be served by physical therapy. There's a difference between developmental milestones, gross motor developmental milestones, and gross motor impairments. And so what I'm proposing, what I would like to see, and this applies across the board. Probably the most difficult one is speech, because if they're not following directions in speech, they probably have some type of a receptive language problem. But OT and physical therapy both, a lot of times kids are qualifying on tests even though they don't have the impairments that need to be addressed with therapy. They may just need some developmental therapy or some home programming. So we have, as an association, have got to go out and train and certify our therapists. And so this is a idea that I've pitched to several people about saying, listen, we have to sit down and take every therapist that are evaluating in the CHMS program right now through a really intense training program. They need to understand they can't just look at standardized testing, they have to look at function. And then we take them through, provide them a certificate. And if they do not go through that training and if they do not get a certificate, then they cannot be an evaluator for eligibility of a program in our state. I think this is a first step in the direction of creating some consistency, but I will tell you, even before I started my company, I worked for 2 very reputable center-based programs in the state. The way we evaluated in one versus the way we evaluated in the other was completely different. They were not wrong or right, they were just different. And I think that's one of the reasons we have so much skepticism from the medical physicians and some of the pediatricians is they don't understand why one organization sends them an evaluation that qualifies a child and has 180 minutes of therapy recommended, and another center doesn't qualify the child or qualifies them with a small amount of therapy services recommended, and those children look very similar. So I think the skepticism that we get from some of the pediatricians who I've spoken with is the inconsistency and just the lack of knowledge of really understanding how to do a very thorough, efficient therapy evaluation for eligibility.
Senator Irvin, you're recognized for a question.
Thank you, I'm over here. 2 questions. So in order to be evaluated and to qualify for therapy, they can just be non-compliant in the evaluation.
So the way a standardized test works, and these are not regulations that Medicaid put. This is the standardized testing author and publisher will say you can ask the question once, you cannot demonstrate, and they must do it on demand.
So, okay, so every
So,
2-year-old
yes.
is going to fail that.
Not necessarily.
Yeah,
but
well,
I
no,
think
pretty
there's
much.
right.
I mean, every 2-year-old, no child is going to do it on demand. So that's.
So you have a high percentage sometimes that are, I think, due to noncompliance, for sure.
Well, of course. I mean, and I know that. I mean, it's primary care physicians as well deal with this. But second question, so yeah, that's a huge problem, which opens the door wide open for every child to qualify, whether they need it or not. But the second thing is there, once a child enters into CHMS, do they come out of it? Or do they come out of it when kindergarten starts?
Well, I'm sorry.
Because so what is an average stay of a child within CHMS? In other words, what's the target to have effective therapy that works when they're released and don't need that therapy anymore? Is there an average?
I'm not really sure there's an average. I think we could probably average it by intellectual disability. So how CHMS works is you might have a child who's a premature low birth weight infant, and they need medical services, nursing services, and they're in and out in 2 years. But that child has a typical cognition level. But if you have a child born with severe, profound cerebral palsy, you have a child diagnosed with autism that you're serving,
Sure.
those kids don't necessarily, are probably going to stay in your program longer. And so because you've got to look across the spectrum of all the different kinds of children we serve, it's really hard to put a number on that.
Yeah, and I understand. I mean, there are some cases where it's gonna be a constant with speech therapy or I understand that. However, I do know that there are children that are being served that are not at all at that level.
I think our main problem in CHMS is the diagnosis of developmental delay, not necessarily a diagnosis of a disability or a medical condition. Developmental delay is a sore subject.
And let me
Um,
ask you about that, because is that being identified by, I see it being identified not just by parents or doctors, but by teachers.
Well,
Your
it's-
child has a problem.
It's,
I can
it
tell you
can
that.
be referred.
You need to put your child on this
Right,
medicine, or, I
mhm.
mean, we hear that from a lot of the folks in the
Well, the
educational
way the
realm.
system works in every state, this includes every state in Arkansas, is we are supposed to make referrals to the program for kids, especially through the Part C program here in our state. So a referral can be made from anyone. That may be what you're talking about. So like a parent, a child care provider maybe who has a child in their classroom that's not doing what they need to be doing. So the referrals can be made from anyone, but a diagnosis should be a physician
Right.
diagnosis. It shouldn't be, the actual diagnosis should only be performed by the physician. So, but even then, there are a lot of kids being diagnosed with developmental delay. I don't understand, I don't know exactly why, I don't know, because a lot of those kids that are diagnosed at, 18 months or a year with developmental delay, a year and a half, 2 years later, actually end up on the autism spectrum. I think there is a question sometimes about labeling them too early or giving a diagnosis too early, so I'm not sure why we see such a wide range of developmental delay diagnoses.
Well, I have my opinions, but, I mean, and thank you for the indulgence. I think there's discipline, there's parents that are throwing their hands up, they're trying to find answers, there's teachers that are frustrated. I mean, I think it's all of that combined, but thank you for the questions, thank you.
Oh, you're welcome, thank you.
All right, Amy, thank you. All right, did you get a chance to finish your,
I think so. That was the biggest
Wonderful.
point I wanted to make.
excellent,
Was on the
excellent. And
assessment
make
piece.
sure you talk to John and make sure you've given him your, okay, good. And if you've
I
done
have
that
not
already,
spoken
great.
with him yet, but I would like to, because I don't think we've been able to talk to the Stephen Group at all yet about the CHMS program.
Okay,
so.
and if you send me an email, we'll get you guys connected, okay?
Thank you. Thank you so
very
much.
much. Thank you. Next, we're gonna have, parents of Human Development Center residents, Jan Fortney and Carol Sherman. I'm now looking to try and buy some efficiency, so is James Brader out here? Is James Brader in the room? Okay, I've got James, you coming after Jan and Carol, but given that you're with DHS, is it you have a desire to talk? Or do you feel like you need to talk, or you feel like we're kind of requiring you to be up there? I would say the latter, it's all been covered. Okay. Okay, no, I understand that. So what I'd like to do, again, without objection from the task force members, is release you from going, and that way it'll give more time for the folks that want to talk CFCO when we're done. And if there's anything in a presentation or things of that nature that we need to see, please make sure Phil gets it so the members can get it. And that if there's any ideas in there that John Stevens needs to consider, please make sure he gets that. But I appreciate you giving us buying some time for folks. So Jan and Carol, and it looks like there's a third person as well, so if you folks would introduce yourselves, you are recognized. And then after that, we'll go to our CFCO folks when we're done with this last element of Section F.
Thank you, Representative Collins. We did have some other parents here. I'm Jan Fortney. I'm the mother and guardian of an adult daughter with profound intellectual and developmental disabilities, and she lives at the Conway Center. We had 3 other gentlemen here, some dads, and they had to go back to work. So Carol and I decided to go ahead and ask our other dad to come up here, so that's why he's up here. I'll let them introduce themselves.
Madam Chairman.
You have to get close.
Madam Chairman and Mr. Chairman, members of the committee, and ladies and gentlemen, I'm Carol Sherman of Little Rock. I'm the mother and co-guardian of John, age 46, whose severe brain injuries occurred at birth. John functions on the level of a toddler. His safe home for many years has been the Arkadelphia Human Development Center.
Madam Chairman, Mr. Chairman, thanks for allowing me to come up here with this group. I am the president of FLCFR. Also serve on the DDS board, which oversees the state's human development centers. And I am the parent guardian of Darlene Pickney, who has resided for 42 years in the state's human development centers. They've kept her alive.
I had about a 10-minute presentation, but in the interest of time, I'm going to make it a little faster, I hope, and leave room for questions. You do have a copy of the whole presentation, and I'm sure you've looked at it already, and I did not want to read every slide anyway, so let's just go through about 3 or 4 of them. And thank you again for the opportunity for us to be able to speak to you today. Our centers serve about, 914 to be exact, I believe. It may not be up to today, but individuals with intellectual and developmental disabilities. Our FFCFR group makes up the parents and guardians and friends of people that live in human development centers. We're a nonprofit, true grassroots organization. We do all of our work volunteer. We advocate for a full range of services and a full continuum of living arrangements with the understanding that one program will not eliminate any other program option. I'd like to take you to slide number 3. As you can see, 62% of HDC residents function at the level of profound DD, and another 18% at the severe level of DD. My daughter is 40 years old, and she functions at the level of an 18-month to 2-year-old child. Many have additional diagnoses and even physical disabilities. Our loved ones would have a very hard time. They might have a good time too, but they would have a very difficult time being here today. They could not sit for long periods of time. They couldn't tolerate crowds of people, and it would be very traumatizing to them. So we don't parade them in front of you out of respect for them. I'd like to take you to, I have another comment about that slide. As you can see, we have 424 health fragile individuals out of 914. And as well as 794 of them, they have to have physician-ordered modified diets. My daughter has to be fed to keep from choking. Many of our loved ones have swallowing and choking issues and dysphagia. I'm going to click through, and you've seen the facts about the HDCs. Their lifetime is an episode of care. There's not just one little specific amount of time for a disease. It's a lifetime. The next slide is the services offered. And you can see that it's not a comprehensive list. Not every individual has to have every service, but Carol and I were just looking at that in case you asked that question. And there are about maybe 4 or 5 on that list where people do not have to have that particular service. The rest of the list, every client has to have that service. Slide number 7. I skipped it, hang on. Slide number 6. As you can see here, there are many services, but HDCs are complete care coordination programs. They're successful. They're historically successful. We believe that the HDCs provide economy of scale. It is more economically feasible to provide these required specialized services by trained professionals on these campuses. And you can see that they're licensed by Office of Long-Term Care, CMS, and we have other accreditations. The requirements for our folks to live at the HDCs, they have to have active treatment. They can't just exist. And that's so important with the stabilization of their lives. There's another page of myths and false statements. I'll skip over that because that's long reading, but it's all, the truths are in blue, and you'll hear some of those things to prove a point that someone wants to make. Sources of funding is important, I thought. HDCs get Medicaid, Medicare, and the HDC provider bed tax. As you can see, the state share was $41 million for FY15, and we believe that that's, good state dollars spent for our health fragile individuals. And they're very vulnerable there, and they're Arkansas citizens. Final comments would be to close care residents the close care residents receive in our HDC programs is essential to their health and safety. HDC residential care is not suitable for everyone. Many individuals with disabilities thrive in other models of care. And we see a need for a range of care options which reflect the realities of the individual with disabilities and their families. We oppose the use of managed care organizations for the residents of the Human Development Centers. They tout that they will make cost savings, but in other states, I'm not sure that has been the case. I think in other states there have been increased deaths of people with with disabilities. And I know in the state of Georgia, we just learned last year that there were almost 1,000 deaths in 2 years span after the DOJ settlement with that state. And they decided to close all their centers. And those parents, we've talked to, we know them. We've seen pictures of their children, and they've died. We don't recommend managed care. It would likely eliminate a model that has proven to be successful. Additional layers of administrative costs, I think I even heard that said in this room, would be added to the Arkansas DD system if you used managed care, because they would have to oversee some of that. So I can't see how that's going to save us money with our population. FFCFR strongly supports the maintenance and infrastructure of the HDCs and with planned and adequately funded improvements. We thank you for the opportunity to represent our loved ones today, and we thank you for your public service. And we would let you ask us any questions.
Okay, thank you very much. So the other two folks at the table, were you going to get a chance to, did you want to share something first?
Yes, two things, and it'll only take a minute, I promise.
Okay, and then what we'll do is we'll go to questions if we've got any. Recognizing we've still got probably 8 or 10 folks that want to talk about CFCO before we leave today at 6. Yes, sir, you're recognized.
Earlier today, I thought I heard a speaker say that there was a waiting list of people wanting out of the Human Development Centers. Let me assure you that is not true. There is no list of anybody wanting out. To the contrary, each center, the state has placed at each center a transition coordinator encouraging people to get out. But even with that efforts to move people in the community, we have now and have always had a waiting list of people needing and wanting those services to get in. Never a waiting list of anybody out. Secondly, and this is what will take 1 minute, since CFCO is such an important topic right now and some decisions you folks are going to have to make, we at FFCFR have not publicly taken a position either for or against CFO. It's going to depend on the sticks and the carrots that are attached to it. And let me say, we firmly believe that a primary reason CFO was created in the first place was to encourage Arkansas and other states like it channel its disabled population away from congregate care and into the community settings. If this should happen in Arkansas, then the state will have totally ignored the fact that individuals with disabilities have a legal right to choice in selecting the least restrictive environment in which they choose to live. The U.S. Supreme Court long ago in Olmstead made that decision based on the needs of the individual involved. The least restrictive environment might very well be a congregate care facility. That's verbatim out of Olmstead. It's no secret that many federal programs are designed and actively involved today in eliminating congregate care as a choice. I submit to you that CFCO is one of those programs. And I am very concerned that the sticks and carrots, or in other words, incentives and the penalties, the state will need to look at very, very closely before they decide to implement this program. FFCFR does not look any further than the title of CFCO to become concerned. It is cleverly named in a very deceptive manner. It is titled Community First Choice Option. That sounds wonderful. It implies CFCO is offering an opportunity for all individuals with disabilities the choice to live in a community. I know I would agree, I think every one of you would agree, that that's a choice that everyone deserves. But it's also a choice that no individual should be forced into. If CFCO was accurately named, the program would be titled Community Only Choice Option. Because by design, CFCO will not allow Medicare dollars or the 6% incentive carrot that accompanies it to flow to any of the state's most vulnerable citizens who reside in the HDCs, unless the state steers that population away from congregate care. Tragically, that would result in many fragile individuals being forced to leave their homes that they now enjoy in the Human Development Centers. There's not one penny in CFCO that will be spent on any individual who chooses to live in a congregate care facility. CFCO simply does not allow it. So let's be upfront with everyone. When we are actually looking at here today is not community first choice option. It's community only choice option. Please consider this as you prepare your recommendations for the governor. And I hope the governor will have serious concerns about entering into any federal program that is purposely designed to discriminate against many of his state's most vulnerable citizens. In closing, on behalf of FFCFR, and on behalf of all of the residents of Arkansas who need and reside in congregate care locations, we do ask for assurances that congregate care programs in Arkansas will not be adversely affected if you should decide to go to CFCO. Adversely affected, that includes but not limited to such things as inadequate funding, frozen admissions at HDCs, forced discharges, loss of services, reduction in staff, downsizing, or facility closures. I hope that each of you will demand these same assurances before making any decisions on CFCO. Now, we're ready for questions you might have.
Well, thank you. And Carol, did you want to share anything before we turn to questions?
Yes, sir.
All right, then Senator Rapert, you're recognized for a question.
Thank you. I appreciate all of you for being here and your patience and waiting to testify. Has your organization had any direct contact or any inquiries from the Stephen Group at all during this process?
No, sir. Early on, I think in June, Carol and I met him and Mr. Kellogg here in this room, and we asked him if he would tour the Conway Center, and he said they already had that on the list to do in August. They have not set the appointment.
Mr. Chairman, I would like to ask if we would make sure that the chairman, because of this issue, has been very serious for every year that I've been in the legislature. And so I would like to make sure that specifically that these families who represent the least among us and need advocates more than anyone else, if we'd make sure to get that information to the Stephen Group and coordinate incorporation of any consideration. And the only thing I'll follow because it's late, but I just want to say that definitely I've toured the center and you have many advocates sitting here, and I can assure you that every time I have to see you here, and I just want to apologize to you because after having to deal with the issues you deal with your families, and then I've seen you up here for years having to basically defend the right for your children, your families to have proper care against people that many times want to just shove them out into community-based situations. And many of the community-based providers tell me that there are obviously some people that cannot be well served because of the level of care that they need. And so I just want to say thank you for coming, and I appreciate you answering my questions so we can ensure that this information is properly accounted for.
Yeah, and I too am very grateful for you coming and sharing your point of view. What I want to do is make sure I defend the Stephen Group, because one of the things that I've been terrible with them is their travel budget. And they've been asked to go to many places, and so I've been very, very restrictive with what I've allowed them to do. So that's a general comment. I'm sure you're not the only folks that are disappointed they weren't able to invest as much time. I'm sure there's many others out there. And I want people to know, do not blame Stevens, blame Collins. It's all my fault. But separately, I do want to make sure, to the senator's point, that any of the information you've got that you feel like you did not get to communicate in that meeting that you had with John in the room, that we get that forwarded, that, another conversation if that needs to happen or whatever. So It's not to say we don't want all that information in front of folks, okay?
Thank you. We will do that. We just actually did introductions. We didn't meet with them much, so
Okay.
we
Well,
just
yeah,
asked them to
let's-
tour, so.
Yeah, I understand that, but let's
Yeah.
make sure that the concepts and the ideas, I know, sir, you shared a lot of different ideas and concepts in your presentation, so let's make sure that he's got that stuff to consider, okay? Yes, ma'am, Carol?
One has to go to the center to understand. One has to meet the people and see the work. Thank you.
Okay, all right, thank you.
Thank
All right, sorry, Senator Cooper, you're recognized for a question.
I'd like to thank you for being here, and I have been to the center in Jonesboro, and I know the condition that, the level of need that those people have that are residents there, and frankly, I'm a little bit disappointed to hear that the Stevens Group hasn't been to any of these. So thank you for what you do.
Thank you.
All right, thank you very much. Now, we've got many people that are signed up to speak for community first choice option, and my goal will be to get to allow everybody to get a chance to speak. So what I'd like to do is see if we could go in groups of 3 or 4. So what I'd like to do is kind of read through the names, and I know some people have had a chance to speak already. Others have said that they're going to give us a letter to be presented to the Healthcare Task Force. So I appreciate folks that have agreed to do that. And so task force members, we will be getting information from people who may not be able, who have chosen to pass on speaking today, to give us their information that way. So what I'm going to do is I'm going to read the first 3 names on the list. And so if you're here, please come forward. Reverend William Robinson, Deborah Bell, Keith Vire. Are the 3 of you here? Okay. Okay, so let me go to the next person then. David Deere. Okay, I'm gonna keep going until I've got 3 people that are gonna come up to the chair. And then we've got Dee Vardy. Is Dee here? Okay. Okay, excellent. And then what we'll do is we'll give the 3 of you each a chance to share your thoughts with the committee, and then we can ask questions of the 3 of you after that, and then we'll go to the next group per the list that's on the agenda. If you'd introduce yourselves and who you're with, and then you're all recognized to speak. Thank you.
Good afternoon for those of you who remain. My name is Keith Vire, and I'm listed on the agenda as being CEO at Arkansas Support Network, and that is true. But I'm here today as the president of the Arkansas Waiver Association. I represent the association and 300 members, providers, families, and individuals who have disabilities. And so that's why I'm here. And I have to tell you, I don't care if you approve CFCO or not. I don't care. What I want is to figure out some way for 3,000 people who have been waiting forever to have services. And those people are not getting, in spite of what was said earlier today, they're not getting an array of services. They're getting state plan Medicaid. They may be getting to go to a day program, some of them. Many of them, I talk to them every day, they're receiving nothing. They receive no supports. And it is, to me, just criminal for us as a state to provide thousands and thousands of dollars of service for some people and to leave other people totally out. And I want to point out to you that the last time, somebody said today, it's an 8-year waiting list. It's an infinite waiting list. The last time somebody moved off the actual DD waiver waiting list was 2010, December 2010. Other people have come out into a priority list because they moved out of they were in custody of DHS or Adult Protective Services, or they moved out of an institution. But the actual waiting list, those 3,000 people, December 2010. So I don't know how you can do the math and equate that to an 8-year waiting list. I just have to say a couple of things in response to my friends. I love my friends who support the Human Development Centers. We are not enemies. They are friends of mine. They may not think so, but I do. And I just have to say that the people that they're talking about can and do receive supports through community programs. We personally, at our place, support people who are ventilator dependent, tube fed, all of those things, people that have very significant behavioral issues. We have never turned anybody away, never will, and we have served people who have been terminated from HDCs. So I would never advocate for people who have lived there for 46 years to be removed, never. But I just don't want the idea that we can't support people with significant needs in the community out there, because it's just not true. Thank you.
My name is David Deere. I'm the Director of Partners for Inclusive Communities, and I appreciate the opportunity to talk to you today. While I'm employed by the University of Arkansas, I've taken leave to be here today and am representing only myself in these remarks. I'm not speaking for the university. And I'll say that I've edited out a lot of what I was going to say because Keith made the points that I was going to, but I do want to echo and say that I am deeply disturbed by the plight of persons with disabilities and their families who choose to receive services in their communities rather than institutions. As you've heard, we have close to 3,000 people waiting on home and community-based services with a wait time up to 9 years, and as Keith pointed out, no one is moving up, no one is getting served. It's a dead end at this point. And I feel that we have a moral obligation to provide services to the people who have patiently waited for years to receive services. We have middle-class families who have moved into poverty and experience diminished health status as parents and siblings have quit jobs and exhausted their savings to care for family members. It's time to correct this situation. Now, personally, I think Community First Choice is a good way to address this, but I'm like Keith. I don't care how we address it. It's time we do it. It is just unconscionable that in a society with the resources we have, that we would condemn people to live that sort of life simply because they're choosing to be in community-based settings. And I agree with what Keith said about needing our institutions. I think it would be heartless to take someone out of a human development center that's been there 40, 50 years. That's their home. I don't advocate for that at all. But it's time that we change things. What we have done is unconscionable, and I hope that you'll find a way to get services to these people. And I want to thank you for your time and your patience today, your service on this task force. You have a most difficult job. I wouldn't want it, trying to balance the needs of all the people and the state budget. That's a gargantuan task. But I appreciate your time and attention to making our Medicaid program even stronger. Thank you.
Thank you, ma'am. If you'd go ahead and share your thoughts, and then we'll go to questions.
Hi, my name is Diana Verity, and I am the mother of a 12-year-old little boy who's diagnosed with autism, and I'm going to try to stay composed. I apologize. We applied for waiver services 7 years ago, and frankly, we're doing fine right now. We could continue to wait for a while. Our son is 12, and he's our only child, and right now, my husband and I provide all the supports he needs to do whatever it is he dreams of doing. He wanted to be a Boy Scout. We provided the one-on-one supervision and redirection that he would need in order to succeed, and he has succeeded beyond our wildest dreams. He wanted to play basketball when he was in first grade. We enrolled him in Upward, and let me tell you, you haven't lived until you've watched your 6-year-old skip all the way from one end of the basketball court to the other, while the other kids are looking at him kind of strange. This year, I had my proudest moment when I got to see how one of the most talented basketball players on his team, who will probably play high school and college ball, supported him and welcomed him and accepted him as a beloved friend. The community has been really good for our son, and we will fight to keep him in the community for as long as we can. But we won't live forever. One day he's going to need the support of waiver services. Without those, then he will be in an institution. And that's not what we dream of for our child. I'll also tell you that I do work in the disabilities field. And I work in an outreach center. And I get calls from families who are on that waiting list. And to describe them as desperate is really an understatement. The very first phone call I got was from a family who had a child diagnosed with autism who literally slept 2 to 3 hours a night. And the mother and the father were sleeping in 4-hour shifts and working 40-hour weeks on 4 hours of sleep a night. And all they wanted was for someone to come to their home and sit with their child so that they could get 1 or 2 nights of sleep per week. I've met young adults with disabilities who dream of moving out of their parents' home and living independently, but can't do so without these supports. I have met families, single parent households. I have met moms and dads who have had to take long leaves of absence from their jobs or even quit their jobs because the support needs of their child were so intensive that they simply couldn't do it anymore. And there is nothing during the summer for a school-aged child who requires that kind of intensive supervision outside of home and community-based waiver services. I am glad that our legislators have taken the time to visit the Human Development Centers. I think that is a wonderful idea, and I am pleased to know that you take the time to do that. I would beg you to take the time to meet the families in your district who have been waiting for these services and to sit down with them face to face in their homes and meet their children and hear from them about the kind of supports that they need to just keep going. That's all I have. Thank you.
Thank you. Thank all three of you. And now, Representative Gray, you're recognized for a question.
Thank you, Mr. Chair. I guess the question I have is the people that are on the waiting list, the only service, to my knowledge, that they are not, the only benefit that they're not receiving, that those that are on the waiver, is essentially a payment, whether it's to a family member or to someone to stay at night. They still have Medicaid, full Medicaid. They have the full range of therapies, the full range of services. I guess I'm just trying to understand what the difference is between the people on the waiver and those off. From what I understand, it's just literally that income part.
No, that is not the case. Medicaid waiver essentially pays for staffing. It does not pay for, it pays for some, modifications in the home, some accessibility kinds of things, but essentially the service that we provide is staffing to help people be able to live independently, to live in their own homes. Most of the people that we support are people who are adults who live in their own apartments. We don't do group homes. They live in an apartment in the community, and they have staff that help them do that. The staffing, the level of staffing that's provided is based on the need of that individual, so it's not like everybody gets the same payment. There are some people in our state who have Medicaid waiver services who actually do have a family member that is the paid staff person. That's sort of unusual, but it does happen. A lot of times it happens because if the place that they live is like a million miles from anywhere, and it's hard to find staff to go there. Sometimes it's because families just, the needs are so significant that families just can't trust another person to do it. But there's no, it is not the case that the only thing they don't receive is money. Families that we support don't receive any money. They receive supported living from us. And the thing I think that they do receive is, you're exactly right, they have the health insurance through Medicaid, and they receive the full benefits of the health insurance, but they don't receive those other services that are paid for through Medicaid. Some people who are on the waiting list for waiver services also attend a day program. I don't know how many. I think the Stevens group talked about that today. So some people do receive that in addition to their health insurance. That's it. They do not receive the same level of service as people who receive Medicaid waiver.
Okay, all it is if we increase that waiver, we increase your business too. And I don't want to sound like I'm very not heartfelt. I have a son with disabilities. I have a nephew with autism. My nephew, more than likely, there is no home modification that could suit him. There is no one that could stay with him. He's got to have round-the-clock care, but his mom's not complaining because she's not on, that she's on a waiting list and not getting paid. She works 40 hours a week and they manage. I don't know. I'm just having a hard time with the waiver when they are receiving a tremendous amount of benefits already, and you make it seem like it's drastic, and without us expanding this coverage to everyone, like the world's going to end.
The world does end for some families who receive no services. And I'll
I
just
take
tell you,
care of my kids that are disabled. I work and take care of them,
and so do those other families.
but I'm not on a waiting list.
That's your choice. I'm not arguing with you about that. But to say that we have families who do have listen, we know that the bankruptcy rate is higher for families that have kids with disabilities. The divorce rate is higher. There's a huge amount of stress in terms of raising a child with a disability. If we can provide some support that allows that child to remain at home, then we save the state millions of dollars. And I understand where you're coming from, but it's hard for me not to resent the fact that you're saying if we increase this, it increases my business. I don't need any more business. I have all the people that I care to serve, but we need the supports for families, not for me.
While I'm in the same boat you are right now, we're able to provide all the supports that we need for our son. And if we had to forego waiver services, that would be fine. It's not a big deal right now. At some point, that won't be the case. So there are lots of people who have reached that point, and those are the parents who I hear from most often. I don't hear from parents who are doing okay. I hear from parents who are desperate, who have had to quit their jobs because they don't have anyone to help out with care during the summer. There are no summer camps where a child with a severe disability can go without some supports. There are no summer day camps where a child with a severe disability can go without some supports. The need for intensive supports is there all the time. Parents who are able to do it, and like me, consider it a privilege to be able to do it. But there are lots of families out there who simply cannot because it's a single parent household, because they're shift workers. I could go on and on and on, and those are the families who really absolutely are in desperate straits. And that's who I'm asking you to help today. Not me, not my son. I'm asking you to think about those families. Because if the phone calls that I'm getting are any indication of what's out there, our family is the exception to the rule.
Mm-hmm.
When you have a mom calls and says, my son is in a wheelchair, I've been doing this for 15 years, he's now heavier than I can lift, and I don't have anybody else to help. So now I'm looking at back surgery because I've just wrecked my own health taking care of my son. That's the kind of folks who need help. They deserve help. We need to provide some support for those people.
All right, and I think I'm just cynical to some degree because a lot of the people that I know that are on the waiver, that are on the waiting list, there really are no, they don't need to be on the waiting list. And I think if we had an assessment in place that actually, in a situation where it was needed, and I'm just cynical, they have not been assessed. The people on the waiting list have not been assessed. So I'm done. I'm tired. Sorry.
If I could make 2 quick points. One is that every individual is different and every family is different. Every individual with disability, whether they have autism, fetal alcohol syndrome, whatever, they have different needs for support. And families have different resources to be able to support them. I will say the fact that the waiting list is indefinite drives a lot of people to sign up for the waiver now so that hopefully in 20 years when they need help, it might be there. So I think I know there are people on the waiting list that wouldn't be there if they had hope of getting services when they need them. But they're going ahead and signing up as insurance for the future.
Here's what I'd like to do. We're going to have one more panel. We've got some more questions here, but while we ask these last couple questions, I'd like Nancy Shaw, Ruth Ayers, and Sarah Israel, if you're here. And I think I've called everybody that was on the agenda. Either I've called you or you shared with me that you're going to submit something else. If those women will make their way up. We've got 2 more questions here for this panel, and then we'll rotate out. So Representative Ferguson, you're recognized for a question.
Thank you, Mr. Chairman. And I apologize, John Selig's gone, so I'm not sure if you can even answer my question. Of the 2,800 people on the waiting list, how many are children? How many are adults? How many are in developmental centers? I'm just trying to figure out the makeup of the existing wait list.
You know, that I don't know the answer to that. I know that in my own experience.
And Representative, on a question like that where we're not going to be able to get the, could we handle that one offline
Yeah, I
rather than
didn't
have?
know.
Yeah,
Does
rather than
anyone
have
else
him
know
guess
the
that.
answer to that?
Sorry, I don't know that.
Yeah.
Well, I guess, can I ask?
Yeah, and I guess what I'm, yeah, it would be helpful. Well, all right, if you've got the answer, come on up, let's do it.
Okay, of the,
No, it's off.
now it's on? Okay, of the 2,800, there are approximately 1,400 children on the waiting list. They're in all sorts of situations. Very few of those are going to be in human development centers, because if you're in a human development center, you actually move to a priority wait list, and you get a waiver slot assigned to you relatively quickly compared to those who are on the regular wait list. A matter of weeks, actually.
And I guess I have a question for you all, especially if you have a child. I guess I didn't realize until today that if we did it, the CFCO, that did not come with supportive living and supportive employment flexibility. So I guess, would you all prefer, if you had a preference, for us to do it with an 1115 waiver that included those services rather than a CFCO?
I would prefer CFCO because it's possible. It's possible. And, you know, back in the session, when we talked and lobbied and we had several people, legislators and other folks who said to us, well, we care about the waiting list and we're going to do something about it, but it may not be CFCO. And since that time, I have heard nothing else, no other answers. So that is an answer that exists and it's possible, so I'm in favor of it. And I'll be honest with you, we don't have very much flexibility for supported employment right now. We fight for it and we do the best we can, but there's very little flexibility for that, and that has to expand no matter what we do.
Yeah, I know Representative Broadway passed that Building
Yes.
Better Futures program that is trying to address some
Yes.
employment opportunities for the
And that's a
disabled
great program.
community.
If I may clarify, I heard that statement earlier today too. Supported employment is not permitted to go into CFCO, but supported living is. Attendant care-like services, that's the bulk of the services that would be within CFCO, yes.
Okay, thank you.
All right, we've got one more question for this group. Senator Aper, please push your button again. I screwed it up.
I think it's on. So
Oh,
thank you,
maybe
Mr.
I
Chairman. Doctor, how do you pronounce your last name?
Vire.
Vire, the waiting list. Are we simply still at a point where that's just an arbitrary number of slots? Is there any other criteria in that waiting list, or is that just if there's just so many slots available, that's just it, and the rest of you have to wait? Is that just simply an arbitrary number?
That 4,200 and whatever the number is? Yes, sir. As far as I know, it is a number that was arrived at by the department in conjunction with CMS, and so it's a number that our state has decided on.
Well, what I want to say first of all is I appreciate all of your comments, especially the comments, acknowledgement that this is not about community-based versus the parents that have children in the centers. I would wager that 99%, probably all of them, if there was a way to have had their children at home, they would rather have done that. And so I have invested a lot of time on this issue. I'm ashamed of the state for not putting the money that's been needed in many of these facilities. Looking over that, making commitments, which I think are very noble. But I believe that children that are profoundly disabled, and the 4,000 of you waiting for help out in our communities, frankly, I believe that's more important than even Lockheed Martin, which we stepped up to help.
Thank you, sir.
And so I'm sensing this, and we need your help, because I have advocated to 2 different gubernatorial administrations of the need. And we left another session again this last time without a commitment for a very small amount needed. And so it's become a moral issue for me. And I make a commitment. I would like for you to reach out, work with us, but you have my personal commitment that we will keep hammering on this, because this is a situation which I think we have, and again, and I know I'm emphasizing it dramatically because I mean it, Mr. Chairman. We can't fix it with this task force, but this legislature can fix it given the right amount of attention. And to your department, we advocated, had money available, had the support of the former governor to get that there, and we still couldn't get things done in our legislature because the other end of our chamber in the House said no. And so I appreciate your time here, and your message is well received. And I'm sorry that for the situations you have to endure.
Senator, thank you for your commitment, and on behalf of the Arkansas Waiver Association, you have our commitment as well.
Thank you very much, folks, for sharing. And now we're going to have our last panel. Ladies, if you go ahead and take your seats and introduce yourselves and who you're with. And if there's anybody else in the audience that had signed up to speak, was on this agenda, if I did not call your name, just raise your hand and come on up. My goal is not to prevent anyone that has waited this long from getting a chance to share their point of view. And with that, if you go ahead and introduce yourselves and who you're with, and then you're recognized to speak. Thank you.
My name is Ruth Ayers, and I'm here as a parent of a child who's on the waiting list.
My name is Nancy Shaw. I'm also a parent of Casey King, who is on the waiting list.
Okay, is this working now? No? Now? The light is on when I was talking.
There you go.
Now? Okay. So my name is Ruth Ayers, and I'm a parent of a child that's on the waiting list.
Say your name right here.
Hi, my name is Casey King.
Sarah Israel, Executive Director of Developmental Disabilities Provider Association.
Thank you. All right, ladies, you're recognized to go ahead and share your thoughts. And we're trying to get out of here. My goal was for us to be out of here now, but obviously we got behind. So please share what you'd like to share with us so we can get your point of view. And then if we've got questions, we'll do that, and we'll just get this finished up when the time is right.
Okay, first I just want to say thank you for staying and listening to what I have to say. I have a fairly unique perspective on the situation because I have a child who receives waiver and I have a child who's on the waiting list. I also am a special educator of almost 20 years here in the state of Arkansas, working with students who have developmental disabilities, mostly moderate to significant and severe and profound disabilities. I also am the older sister of a 41-year-old younger sister named Rita, who has significant disabilities, and my parents and my sister moved out of state because she was not able to get community services that were going to benefit her to have the type of life that our family wanted for her by staying here in the state. I brought the picture of my child who's still on the waiting list. Another interesting fact is that both of my kids are adopted from the Arkansas foster care system. At the time, the reason my youngest does have waiver is because she required care so significant that even in her foster care placement, they could not take care of her without extra support. But with the waiver, she is able to live at home, go to a public school. It is a self-contained classroom, but she's thriving. And for her future, although I would never want folks who do reside now in human development centers, that's not the future that I want for my child. That's now in this year of 2015. In my day-to-day work, I see students that in schools, and I know sometimes public schools and special ed in Arkansas gets a bad rap, but I work with school teams who on a daily basis help those students become as independent as possible. And we've talked here about evidence-based practices today. Evidence-based practices show that the correct programming for those students in public school can help them live in the community and can help those students not have to be institutionalized. But what happens is we put those programs into place in our schools, and then our students graduate and they do not have choices. I cannot tell you the number of times that I've worked with a students who are nonverbal, students who use wheelchairs, students who do use trachs and need different medical care, that we had them on job sites and job training programs, even where they did just part of the job. But the quality of life that gave that student and the dignity that brought to those students' families was so profound. And then they graduated, and I've talked to a lot of these parents lately. There's been parents who had to quit their jobs because they don't have choices for their students when they get out of school and when they're grown. For my child who's still on the waiting list, I've raised him to where he thinks he has lots of options. I hope I haven't lied to him. He still thinks he could have the chance to join the military. You can see from his picture they wouldn't let him in, and he thinks he could go to college. But the other day he said, I think maybe I've decided I don't want to join the military when I grow up. And I said, well, that's just fine, but I do want you to have a job. Our joke is now you can live at home once you graduate from college, and you don't have to go to the military, but you have to have a job. And I just pray that I'm not setting him up to live in a state that does not want to provide the services for him to be able to do that. Sometimes when I go, my sister now lives in Iowa. I had to drive 12 hours over Labor Day weekend to see her because she could not stay in Arkansas and be able to have the life that she deserves. And I can tell you that her first placement was more of an institution. And people told my parents that that's what would be best for her. But she now lives in a small group living situation. Her behaviors have decreased. She's happier, and she gets to go out and do community things such as go to church, shop in the community, help cook meals for the other adults that live with her. And she's part of her own family as an adult. She's 41. She deserves that. She shouldn't have to live at home with her parents the rest of her life. And now I'm facing the situation where my parents are older now. I don't have the option to bring my sister here right now. She would not receive the services for her to have the quality of life that she has living in Iowa. But she's 12 hours away. The other thing I'd like to bring up is just with the DHS situation, because I did adopt both my kids from DHS. I did think that my son Rashawn was already on the waiting list. I was informed by DHS that he was on the waiting list while he was in foster care. About a year after the adoption was final, I called and to find out which number he had gotten to, and they couldn't find him. He somehow had dropped off the waiting list. So I started that application process again, and we talk about, you know, making sure that kids are eligible. If you haven't filled out the waiver application, it's a long application, and I have often wondered how some families even get through the application process. It took me quite a while, and I know quite a bit about the services available. So he's officially been back on the waiting list for about 4 years. We were at, I couldn't find the exact number, but it was somewhere around 2,384 in 2012. In February of 2014, he'd moved up just a few slots to number 2,372. I called yesterday, and it's because of the going through and making sure people who didn't really qualify are off the list now. He had moved up to 2,156. But even if over the next 4 years, he is able to move up 228 spots, that only puts him at 1,928. So I figured that if the list moves like it is moving now, it would take 38 years for him to receive any services. He'd be 50 and I would be 84. So I don't really feel a lot of support from our state to help my family. When I put him on the waiting list, and we still do fine as a family. We can meet the needs of the kids. They're 12 and 9 right now, but I have to think to the future. I have to think what is going to be available when I might not be able to care for him, and I do not want his future to not be full of choices. I do not want the only option to be sitting on the waiting list or going to an institution. Thank you.
Thank you. Next, ma'am.
Yes, my name is Nancy Shaw. This is my daughter, Casey. Casey has been on the waiting list for 7 years, and I figured it up like you did. Casey will be 44 years old if the list keeps moving the way that it does. I thought I knew what I was going to say when I got up here, but after listening to you talk, I have to tell you that you are lying to your kids. Casey graduated high school in May, and all of her life we have tried to teach her that because she has Down syndrome, that should not limit her, that should not stop her from being able to do anything. She graduated high school, and we're stuck. Period. There are supported job employment. The employers are so limited. We live in Hot Springs. It's a little bit better in Little Rock, but there are so few places that actually would look at hiring her without a job coach or without some kind of supported employment. She took a job last week because she'd been sitting on the couch. When you get anybody that lives a sedentary lifestyle who already has a predisposition to being overweight, you end up with everything from hip problems and back problems to cardiovascular problems to diabetes. So getting this population, getting my daughter out into the community, keeping her active, her life depends on it. You know, it's gonna cost the state more money to care for her if she gets ill because she's just been sitting around watching TV. But when she graduated and we started looking for programs, there was really nothing out there. We came back from the Arkansas rehab one day, and Casey and I were both so disappointed. We sat on my bed and we cried. And I told her, I said, Casey, we can cry for 10 minutes. And then we have to get up and figure out what we're gonna do about it. I heard some things today that really bothered me. First of all, as far as whether or not what services we are receiving being on the waiting list. Yes, we do get Medicaid. Kids without being on the waiting list get Medicaid. So far, in the last 60 days, I have gotten a letter from our waiver caseworker saying that there was a discount day at the zoo. That's the extent of our support that we're getting from waiver right now. Another thing that I heard is that parents of people with disabilities will take everything you've got and then want more. That's not true. We don't want everything that you have. We want our children to have a fair shake at a life that they deserve. You know, had I known that this was going to be the case, you know, I wouldn't have put her through school. I wouldn't have sat through IEP meetings and, you know, the way in the DDS Governor's Disabilities Training if I knew that once she graduated high school, it was just done. Like your parents, I looked at what we have in our state, and I went back to school because I needed to be able to make a living so that I could move my daughter out of the state of Arkansas. We love it here. But if that's what it comes down to for her to have a chance, then that's what we have to do. When you talk about the people in the HDCs being the most vulnerable of our population, that our developmentally disabled are the most vulnerable, whether they live in the HDC or they live in the community. If I die tomorrow, Casey has no options. And I'm asking you, begging you, to please give my daughter the chance to live the life. Look at her, she's an intelligent, personable young woman. I also have a niece who lived in the state of Michigan. She was 36 years old and very medically fragile. She had cerebral palsy, was blind and deaf. They moved, when the state of Michigan kind of started fading out with that, she went to a group home. She lived 10 years there, and the family agrees that it was the best 10 years of her life. The fact that I hope that our state cannot justify spending the numbers that I figured out quite a while ago were $117 million on 900 people in the HDCs. I don't think that they should be yanked out of the HDCs and put into an institution. I just believe that the money should be dispersed more fairly. I think we ask for your help and your support, whether community choice is the answer or it isn't. We need to do something about this list. Casey needs a life. She deserves a life.
I deserve it.
Say that again.
I deserve it because I have Down syndrome. Oh God.
Let me tell you, Casey's got some shoes on that rock. I've submitted a written statement to Phil Price, and I would just like to thank you, Senator Raypert, to your commitment to doing something about the waiting list. And I will just echo my colleague Keith Vire with the Waiver Association that you also have the commitment of DDPA to help work toward a solution. Thank you.
Thank you. And Senator Bledsoe, you're recognized for a question.
Thank you. Ms. Shaw, I was very interested in your testimony, and you were talking about jobs. In my district, specifically in Rogers, we have Open Avenues, which is a place for people who need jobs that are developmentally delayed, or there is a problem, like there are several Down syndrome children there. There are others that are in wheelchairs. There's some that are emotionally delayed. I mean, there are just so many different types of diagnoses there. Why, I mean, do you not have anything like that? And they are paid for their work. They go to work, they work at a job, and then they're paid. And there's a bus that picks them up and takes them there. Is this not something that would be applicable in your life with your daughter, or is there just no service like that in your area?
I believe that what you may be referring to, may be considered a sheltered workshop. And Casey just started working at Abilities Unlimited. It is a sheltered workshop. It was definitely a last resort. They are a discriminatory environment. If you took all the black people and said, we'll give you a job and we'll even give you a ride there, but you have to work at this place. How well would that go over? If you took all the Catholics and said, we'll give you a job, but you have to go work at this place and we'll even pay to get you. And guess what? We aren't gonna pay you minimum wage, but we're gonna pay you by how many pieces you actually turn out.
Well, I was
So,
at-
I'm sorry,
ahead,
in the
excuse me.
least case, it is it is a bare minimum of an option.
Okay, well, I was at Open Avenues 2 weeks ago and toured the building, talked to some of the people that were working there, and they seemed happy, and they seemed very proud of their work. So that was just an option. Okay, the other thing is, what services are you lacking? What do you need besides a job for your child? Tell me what you need.
Casey, well, like the parents here, as a single parent, I supported both of my children on my own. Now that Casey is an adult, things have changed. Casey wants to live on her own, whether it be an apartment. Her ultimate goal, when we first started looking for a job, we went to the Beehive in Arkadelphia, and she fell in love with it. That's what she wants to do. We don't live in Arkadelphia, and so she needs waiver to live in an apartment to work in Arkadelphia.
So you need the
We
CFCO.
need, well, not really. We need supported employment, we need supported living.